morning. Good morning, can you hear me? Dr. Vijaya Krishnan. Yeah, good morning, Dr. Vijaya Krishnan. Can you hear me?
Yes, sir.
Yeah, we can hear you. We can hear you. Okay, so I'll finish the other thing and I'll join you here, okay?
With pleasure, sir.
Okay.
Yeah. Good morning, very, very good morning on this Sunday, and good morning to all of you, and a warm welcome and heartiest welcome from Sun Pharma for the dear and respectable delegates for today's webinar and the respected panel of today's webinar. Sun Pharma Pharmacare Division, in collaboration with the Indian Academy of Otorhinolaryngology and Head and Neck Surgery, organizing the webinar today. It is indeed a great privilege and honor for Sun Pharma and Pharmacare Division, as you know, that which is dealing with the brands like Cepodem XP, Raciper, Betavert, and Montek FX. And today's webinar by IAOHNS is webinar series 6. And today we have the topic is on nuances in endoscopic sinus surgery. And it's a great privilege to have such a galaxy of prominent speakers today, like Dr. Neelam Vaid from Pune, Dr. Nishit Shah from Mumbai, Dr. Prepageran Narayanan from Malaysia, the senior most Dr. Milind Kirtane from Mumbai, and Dr. Brigadier Ramakrishnan from Armed Forces, and of course, Dr. P. Vijaya Krishnan from Chennai. And to moderate the session and to lead this total webinar today, we have the privilege of having Dr. K.K. Handa from Gurugram. And I would like to give a small introduction about Dr. Gurugram, though it is not required because many of you are knowing him very well. Dr. K.K. Handa is presently working as a director and head of the department for ENT and neck and surgery at Medanta Medicity, Gurugram. Dr. K.K. Handa has more than 24 years of experience in this specialty. Dr. K.K. Handa is among the foremost voice of laser surgeons in the country, I would say it that way. Dr. K.K. Handa is the founder secretary of the Association of Phonosurgeons of India from 2004 to 2007 and president of the same from 2010 to 2013. Dr. K.K. Handa is current president of our Indian Academy of Otolaryngology, Head and Neck and Surgery. So this is a small introduction, though it goes pages by pages, but I would like to restrict with this. And once again, my heartiest welcome to all the delegates, and once again, my heartiest welcome to all the panel members, the galaxy of stars today, to today's webinar. And I'm very, very sure, and I can give you the assurance that today's webinar will have lots of take-home messages, and it will be a very, very interesting with our speakers, through our speakers. So with this, let me remind, once again, thanks from Sun Pharma Pharmacare Division, and over to Dr. K.K. Handa. Dr. Handa, please.
Thank you, Mr. Mahendra, for your kind introduction. I welcome all the faculty and all the delegates attending this webinar. This is from the auspices of Indian Academy of Otolaryngology, Head and Neck Surgery, 6th in the series. Those who've been regular in attending, we've had an immense response to all the previous 5 webinars. And today it's a very current and very popular topic, nuances in endoscopic sinus surgery. And we have eminent speakers. There will be 4 talks followed by a panel, which will be moderated by Brigadier N. Ramakrishnan. Now, we have 4 very eminent speakers. First, Dr. Neelam Vaid from Pune. She'll be talking on the frontal sinus. Then we have Dr. Nishit Shah from Mumbai. He'll be talking on extended endoscopic transsphenoidal surgery. Then Dr. P. Narayanan from Malaysia. You know him all very well. He'll be talking about intraoperative bleeding in endoscopic sinus surgery. And finally, Dr. Milind Kirtane, the old warhorse. He'll be speaking on spontaneous CSF Rhinorrhea. And finally, the moderator. So it's a long program, about 3 hours, but I think it is worth every bit. So I I request the audience to please listen to everything carefully. Put forward your questions to the moderator. I'm sure they'll be forwarded to him through the chat box. Mr. Mahendra, kindly see to that he gets the questions. And during the moderation of the panel, he can take up some of the issues which have not been repeated before. And I request all of you to become members of Indian Academy, which is foremost in getting out good academic programs, which are benefiting all the ENT surgeons all over the country, the students, postgraduates, and each of these is the crux is quality academies. Thank you. Before I hand it over to Brigadier Ramakrishnan, a short introduction about him. Brigadier Ramakrishnan is a product of Armed Forces Medical College, graduate, postgraduate, and he has stayed as professor and head of ENT at AFMC Pune. He's during his army tenure, he's a current serving brigadier in the Indian Army. He's held different positions, teaching. As you know, in army at times there are administrative positions also, both ways. Today, he is posted in Ambala and he's Brig Adam of the Corps there. And he is his focus areas have been cochlear implants, endoscopic sinus surgery, pediatric airway surgery, and he's been a teacher, examiner for various postgraduate, undergraduate activities, exams, and faculty for different workshops. And I have had the privilege of interacting with him in professional capacity and in during our AFMC days. And I hand it over to Dr. Brigadier Ramakrishna to carry out the further proceedings.
Thank you very much, Dr. Kumud Handa. A very good morning to all the eminent faculty and so all the delegates who have registered into this webinar. This webinar, as was brought out earlier, is the 6th of the series of the Indian Academy of Head and Neck Surgery. And today's main thrust is on the nuances of the endoscopic sinus surgery. And we have very eminent speakers, as was brought out. My request is to all the delegates is, as and when you have questions, you can post them on the website and we'll be able to see them on a different page. And towards the end of, after all the speakers finish their talk, we'll be having this question and answer sessions where I'll be asking the questions to them, and of course they'll be in a position to answer and clear all your doubts. So without much ado, we will go on to the talks straight away. And the first talk would be by Dr. Neelam Vaid. And let me just give you a brief introduction about Neelam. She has been, she's a product of the Vijaya Medical College in Pune, and she has been in the specialty for about 2.5 decades. And we go a long way from those days. And she has been a teacher par excellence and a professor in ENT. And over a period of years, she has developed her subspecialty into endoscopic sinus surgery and also cochlear implants. She heads an organization called the Big Ears in Pune. And there are a whole lot of accomplished children and benefited children who've been brought back to the mainstream of life with her indulgence. And today, apart from this, she has also some other additional qualities. She is one of the renowned marathon runners, and I don't know how she has been missing her marathon the last few months since the onset of this COVID situation. And I'm told she's upgraded herself from marathon to ultra marathon also, and doing her rounds in South Africa. So anyway, all this, I mean, this all talks about her endurance and stamina and all that goes with it. Without wasting much time, I hand over to Dr. Neelam Vaid on her topic, the enigma of the frontal sinus. Dr. Neelam Vaid.
Thank you so much for that introduction. I'm just humbled. And yes, I did not give up my running during the COVID times. Instead, one of the reasons I logged in a little late was because I had a long run on Sunday. So COVID, no COVID, running still continues. At the outset, firstly, thanks to IAOHNS for the invitation to be a participant in this webinar and share some of what I have learned over the last decade or so of endoscopic sinus surgery. Thanks to Sun Pharma for facilitating this whole activity so that we can reach out to more people. My first message to everyone would be, during these challenging times, I hope all of us will stay safe and healthy, not just physically, but mentally too. And I hope we all survive 2020, as we now say. It's just, let's get over this year and hope 2021 is going to be a much better one. So coming to my topic for this morning, I'm going to be talking on the enigma of the frontal sinus. The reason I think it's an enigma is when I started learning endoscopic sinus surgery, and this was as far back as, about 2000, 2001, we really did not have that sort of instrumentation, that sort of hardware which today we have. And the frontal sinus for most of us really was one that had a pretty long learning curve as far as developing our surgical skills for this sinus were concerned. And what I'm going to share with you this morning is maybe a couple of how we got over it, how my own journey evolved. And maybe I don't say I would be able to address all diseases of the frontal sinus, but at least to some extent, I think the surgical skills have improved. I think this saying by Dr. Kennedy is very apt, that if any one of us wants to really get into becoming not just a good endoscopic sinus surgeon, but someone who can handle the frontal sinus confidently, we have to follow the same principles of care and dexterity that we use for stapes surgery. So a good otologist, someone who does good stapes, by and large should be able to do good endoscopic sinus surgery, and especially good frontal sinus surgery. The proposed plan for this morning's talk is I'll touch briefly on embryology. We'll quickly look at and revise the anatomy and radiology with specific focus on the frontal sinus. We'd look at surgery with special interest on the various instrumentation that's needed, techniques, a little bit on post-op care. And quickly, if time permits, I'll talk a bit about refining, limitations, complications. I will not be covering stenting as because of limitation of time, and a little bit on balloon sinuplasty. When we look at embryology, this is one sinus that is not present at birth, and it's only at about 3 years that you start to see the invagination of this sinus, or the growth of this sinus into the frontal bone. It then grows very, very slowly at a rate of about 1.5 millimeters per year. And it will reach adult size only by the time the patient is about 20 years. The reason I mention this is because a lot of us in our practice will get these little children who are referred to us by pediatricians saying, oh, this child has frontal sinusitis. And it's very important to remember that if you don't have a frontal sinus, the chances of you having frontal sinusitis are far too few. So just keep this in mind. The aim of surgery, and this is not just for the frontal sinuses, but if you look at endoscopic sinus surgery, by and large, it is going to be, you want to open out that entire drainage pathway. In today's talk, we're going to focus on the frontal sinus drainage pathway. But more importantly, it's not just enlarging and opening out the drainage pathway, it is to maintain the mucociliary function. So if we make a big opening, but you've damaged the entire mucosa around that opening to the point where the cilia are no longer functioning, that surgery is bound to fail sooner or later. The surgical philosophy behind any surgery would be, firstly, we've got to understand the anatomy we are dealing with, which in this case is really important because there are so many cells here. Understanding the cellular structure and where it is that it is draining around these cells is very important. In our mind, before we start operating, there should be a plan there for each and every cell. And more importantly, before the patient comes onto the operating table, there should be appropriate medical and anesthetic strategies in place to see what you're doing. This is not the surgery that you can do with an extremely bloody field. Everything is red all over. You can't see and you're just probing around in that whole mess. This is not a surgery that you can do there. For this particular sinus, there is very, very specific and appropriate instrumentation needed. And if we are, as surgeons, going to grow to the point where we're going to be, really dealing with frontal sinuses, I would urge all of us to really invest in the appropriate instrumentation that this sinus really needs us to have. Now, quickly, let's look at a little bit about the anatomy. There've been a lot of words used, and they're used, intermingling. So you'll have someone talking about the frontal recess where that person actually means the frontal ostium. So each word has a very specific thing in anatomy. And each of these is basically doing one thing. We're trying to find out what's the frontal sinus drainage pathway. The frontal ostium is that narrow part that sort of is behind the frontal beak. That's the narrowest part. Anything above the frontal ostium is the frontal sinus, and anything below the frontal ostium is the frontal recess. So it has been called before like an hourglass appearance, where the narrowest part is the frontal ostium. Anteriorly, the frontal ostium is defined by the frontal beak. Above that, the frontal sinus. Below that would be the frontal recess. And all this will constitute the frontal sinus drainage pathway. For years and years, we've been taught that the frontal sinus drainage pathway was always dependent on the attachment of the uncinate. And this was something that I think till quite recently we spoke about, that, if the uncinate process was attached to the lamina praeparatio, then the drainage was between the middle turbinate and the uncinate. And usually there would be this end over here called the recessus terminalis. If the uncinate process was attached to the skull base, then you'd have the drainage lateral to the uncinate process. And similarly, if it was attached to the middle turbinate. Now, this is extremely good theoretically. Practically, you never see things like this because the uncinate process invariably is multi-pronged. So you may have an uncinate process that's got an attachment here. It's also got an attachment to the skull base, and it's also got an attachment to the middle turbinate. So for years and years, this thing is what we followed, but now it's been changed. And now when we look at the frontal sinus drainage pathway, what we are really looking at is what are called the frontal recess cells. Now the frontal recess cells are the cells that are lying in that frontal recess, which is mostly below the frontal ostium, as we discussed before, and they are divided into two types: a single agar nasi cell and multiple frontal ethmoidal cells. So the frontal recess cells contribute an agar nasi, and these other cells, which together are called the frontal ethmoidal cells, which we will in the future slides understand what they are. Now, the frontal ethmoidal cells were classified actually by Professor Wormald in this book in 2008. And this is the classification that most of us now are following, and not the old one, which was by Professor Kuhn, where he had described it as type 1, 2, 3, and 4. So we are now using this new classification. For those of you who are interested, this is the book. It's now been, of course, updated, and I will show you subsequently that too. So what Professor Wormald did was, when he classified this, the entire classification was based on the position of the cell in relation to two things: the agar nasi and the frontal beak. And that made it easier for us as surgeons, because depending on where it was in relation to the agar nasi or the frontal beak, as a surgeon, you were deciding a different plan for that cell in terms of instrumentation. So what are these cells that Professor Wormald has described? When we look at the first type of a frontal ethmoidal cell, that was a cell which was a single cell above the agar nasi, but below the frontal beak. So in relation to the agarnasa and the frontal cell, frontal beak, you have one single cell which is between the agarnasa and the frontal beak. And this was the type 1. Now the type 2 was maybe two or more cells above the agarnasa, but never crossing the frontal beak. So in relation to the frontal beak and the agarnasa, you would have a couple of cells which were above the agarnasa, but always below the frontal beak. This was Kuhn 2. Now Kuhn 3 was maybe 1 or 2 cells which were again above the agarnasa, but in this case, they went over and above the frontal beak. So here radiologically, you can see this is the agarnasa, and this is this one cell, which is the type 3 cell, which is going above the frontal beak. The important thing to distinguish this type 3 from a type 4 is that when you look at the perpendicular length of the frontal sinus, a type 3 cell by definition never crosses more than 50% of this vertical length. So a type 3 cell, to revise, above the agarnasa, crossing over the frontal beak, but never over 50% of the length of the frontal sinus. Now the type 4, the way we had learned it originally, was that it was supposed to be an isolated cell, and this is what we had been taught for years and years. But that's not true. A type 4 could be a cell which is above the agarnasa, but could be crossing 50% of the length of the frontal sinus. So this is what's called a type 4 cell. So a type 4 cell is actually a type 3 cell which has gone so high up that it is lying more than 50% of the length of the frontal sinus. So this was how, we had defined, the 4 types of the Kuhn cells. Now the next cell was something called a frontal bular cell. Now the frontal bular cell, and all these words are a little confusing, but if one just remembers the way they grow into the frontal sinus, it just becomes easier. A diagrammatic picture over here, this is your bulla. This is the suprabular recess. If you have anterior and superior pneumatization of the suprabular recess into the frontal sinus, that's called a frontal bular cell. So a frontal bular cell radiologically will be this cell. That's the bulla, that's the suprabular recess, and a pneumatization that grows superiorly and anteriorly into the frontal sinus is what we call the frontal bular cell. Now the importance of the frontal bular cell is the fact that most instrumentation here has to be posteriorly. If you put any instrument here and try and break this cell, you may end up injuring the skull base. So you've got to remember that the frontal bular cell, your direction of instrumentation is going to be very different from when you are dealing with a Kuhn 3 or a Kuhn 4 cell. So again, this is what it will look like. You will have the agarnasa over here. This is where a type 3 cell would come, and this is the frontal bular cell. Now the importance here being as I mentioned, the way the instrument goes. So the instrument always goes into the drainage pathway. For the frontal bular cell, the instrument is going to push the cell wall posteriorly. For the Kuhn cells, the instrument is always going to push this, the wall of the cell anteriorly. So we need to remember this because doing it the opposite way can have implications on causing complications. Now the supraorbital cell is the cell that more often than not, and when I look back at maybe what I thought I had done good frontal sinus surgeries in the beginning years of my experiences with endoscopic sinus surgery, I think I more often than not open the supraorbital cell and not the frontal sinus. Now the supraorbital cell is a cell which extends over the orbit. It also drains into the suprabular recess. The important thing is if the patient has a supraorbital cell, that vessel that we are really petrified of when we start endoscopic sinus surgery, the anterior epimoidal artery, is pushed much more posteriorly. So you are considerably safe when you're operating anteriorly. And the if you see an opening easily when you're doing endoscopic sinus surgery, more often than not, that's a supraorbital cell, not the frontal sinus. Now, this was the most recent classification that's been given in 2018. And again, it's been promoted by PJ Wormald. What they've done is now they have tried and defined the cells on the basis of the drainage pathway. So if the drainage pathway was such that it's been pushed posteriorly, then these were anterior cells. Posterior cells would push the drainage pathway anteriorly, and medial cells would push the drainage pathway laterally. The whole idea of this classification from a surgeon's point of view is insertion of the instrument. Because if you know you have anterior cells, your instrument is going to come posterior to these cells. If you know you have posterior cells, the instrument is going to come anterior to these cells. And similarly with medial cells, your instrumentation is going to go laterally. I personally still am following the old classification. I think it's going to take us some time to get used to this. At the end of the day, classifications are meant to make your life easier. If you feel you are more comfortable with the old one, please use that one. This is something that's just come in 2018, and I thought it would be apt that we should introduce this classification to all the delegates. Now, the other important thing anatomically is the size of the agar cell. As a surgeon, if you're going to be doing the first couple of frontal sinus surgeries, I would urge you to choose cases where the agar is a big one. If you have a big agar, by and large, you will have a very big frontal recess and a small frontal beak. Thereby, the chances of your doing good surgery in this area are a little easier. Vis-a-vis, if you have a small agar nasi, then usually we have a very big frontal beak and a very, very small frontal recess. This is challenging, and in some cases, we even need to do drilling like a modified Lothrop. So for those of us who are in the beginnings of our learning curves, try as much as possible to use these cases till one is a little more confident with using this different instrumentation, and one can tackle surgeries with this sort of an anatomy. Now, what is it specifically that we look at in radiology for frontal sinus surgeries? You have a lot of talks that we've had on PNS radiology, and I'm not going to go through all of them. But when I look at radiology from the point of view of frontal sinus, what I really want to know is the degree of frontal sinus pneumatization. I want to look at the frontal sinus drainage pathway because my instruments are going to go in the direction of that frontal sinus drainage pathway, and the axial cuts gives you a lot of information here. So get used to seeing this in normal scans before you can see it in abnormal scans. And I think this part I was influenced and taught this by Nishit. Before this, I really had no confidence in looking at axial cuts, and over the years with a lot of workshops that we've done together, have acquired some sort of skill on being able to read them. The size of the frontal recess, very important. Look at it in radiology, see the anatomy there, see what are the cells which are compromising it, and always look at where the anterior ethmoidal artery is. Because when you are doing frontal sinus surgery, this artery is pretty close by, and you just want to know where it is just so that you steer clear of that structure. The other things that one must look at, and this is especially important if one is doing maybe a revision case, etc. Like we said, look at this length of the frontal sinus. This is very important. That's the measurement from the nasal beak up. This one is important, especially if you're planning trephining. So always assess the superior and lateral pneumatization of the frontal sinus. The antero-posterior diameter, which is from the nasal beak to the anterior skull base, is the one that's giving you an idea of how big or small the frontal recess is. So measure it. You don't necessarily have to put a figure to it. You can just have a visual impression of whether this is one that's going to be easy, whether this is one going to be difficult. But in frontal sinus surgery, I always make it a point to look at this. and always look at the thickness of the frontal beak. This should, as far as possible, never exceed 1.5 centimeters, because if it's more than 1.5 centimeters, you are maybe looking at this patient requiring drilling and thereby maybe a modified endoscopic Lothrop. So very important that in radiology, in addition to the normal things that we look at in PNS, look at these three things. They will help you a lot when you're doing the surgery. Always evaluate adjacent anatomy. Look at the skull base, especially the Keros classification, because you have instrumentation that's moving medial to lateral, and you want to know what's the depth of the skull base in that area so that you inadvertently don't damage that and cause a complication. Look at what's happening to the medial orbital wall and the anterior artery. So in radiology, in addition to looking at what I've already mentioned, do make it a point to just focus on these three things before you go on with the surgery. Instrumentation for frontal sinus is very important. And I think as a learning experience, I went through a 30-degree, a 45-degree. But now I think if one is looking at frontal sinus surgery, you definitely have to get comfortable by using a 70-degree scope. That's the best one. For 70-degree scopes, you need angled instruments that are bent at 90 degrees. Why do you say that? All instruments that will enter the nose when you're doing endoscopy will be coming from below the scope. For one to be able to visualize what the end of the instrument is doing with a 70-degree scope, we need an instrument that's 90 degree. Now, if I was to use this instrument, which is 45 degree with a 70-degree scope, I am most probably not even going to see what the tip of that instrument is doing. So very important that you get comfortable by using a 70-degree. Initially use it for diagnostics. As you get more and more comfortable, you will slowly develop the skill of being able to do it with instrumentation. This is the special instruments. I have two of them. These are cold steel, and these are all the malleable instruments that I need when I am doing frontal sinus surgery. You need curettes of different sizes and angles. You need the giraffe forceps. You need them opening side and front to AP and side to side opening. I'll be showing you these in surgical clips. Ostium seekers or KUNs. The malleable ones are amazing, and they make your life really, really simple when you're doing frontal sinus surgery. Keyhole suction is something we all need to use when we're doing frontal sinus surgery. This is one sinus which is unforgiving. More often than not, and I remember one of the reasons why I was so scared of frontal sinus surgery is because when I started it, this was ingrained, told to us time and time again that almost 60% of frontal sinus surgery or patients coming back for surgery are iatrogenic in nature. So the mucosa around this area is unforgiving, and you must get used to using this keyhole suction, which works great as a pointer and as a suction and really helps you in preserving mucosa. So urge again all of you to, acquire these. Powered instrumentation only after you are comfortable and experienced. Again, because with a 70-degree, you're going to be using almost 120-degree blade. So you need to really get comfortable with doing that. I would first say, develop your skills with using cold steel and these malleable instruments, and then slowly and steadily, you will develop the skills to be able to use powered instrumentation there. There are various surgical approaches for the frontal sinus. Today, we are only going to be focusing on endoscopic, especially the frontal sinusotomy. The others, because of limitation of time, I will not be touching on today. Now, when I look at the surgical steps for a patient who has a frontal sinus disease, what is it that I have a surgical plan in my mind? The surgical plan that I have in my mind is what I call the ICICI rule. And I'm not a shareholder in the ICICI Bank. So please excuse me for using this. I first identify the area of recess. This is done with a 0-degree. So I'll identify where the recess is when I'm initially starting surgery. After that, I will complete an anterior and a posterior ethmoidectomy. If the patient needs the sphenoid to be done, I'll be addressing it at that time. When I finish that, I now have achieved what is called an identification of the level of the skull base. So I know where the skull base is. And then I will follow the skull base from a posterior to an anterior technique, something like what Professor Vaid had told us. And then I complete my frontal recess work. Lastly, I'm identify that I'm definitely in the frontal sinus, and that's how I will complete the entire surgery of the frontal. So I never do the entire frontal surgery work or the frontal sinus surgery in the beginning. So I repeat, first identify the recess, complete the remaining part of your endoscopic sinus surgery, identify the level of the skull base, come posterior to anterior, and then complete the entire frontal recess dissection and identify the opening of the, or the anatomy of the frontal sinus. Now, the challenge that you have when you are doing endoscopic sinus surgeries, how do you identify where is the frontal recess? And we have a lot of anatomical structures that are giving us the clue. The first one is that we know that, the opening or the natural ostium of the maxillary sinus and the frontal ostium are in the same perpendicular plane. So that is one. The second is that the anterior wall of the bulla collaborates, if you draw a perpendicular line superiorly, to the posterior part of the ostium of the frontal sinus. So the first way, if you don't want to use angled instruments at least till now, and you want to identify where is your area of the frontal recess, you do what's called the intact bulla technique. Now this is a Kunz seeker, which is what I'm using. Excuse me for the quality of the video. This is a slightly old video. We are now in the right nostril. This is the middle turbinate. That's the lateral nasal wall. That's the septum. That's the bulla anterior wall, which I have left intact. And with the Kunz seeker, in the same perpendicular plane as the anterior wall of the bulla, I am now probing here, and this is very tactile, to find the opening of the frontal sinus. And that polypoid structure there is telling me that that's where the opening is going to be. So one way of your defining or trying to find out the possible place where the frontal ostium or the frontal sinus drainage pathway would be is by keeping the bulla intact. Now, this was promoted a lot in the beginning because the anterior ethmoidal artery is always posterior to this. So if you do this by doing this the way I have shown you here, the chances of inadvertently damaging the anterior ethmoidal artery were very less with the intact bulla technique. So the intact bulla technique is one way of identifying it. The other one is the one that's been promoted a lot by Professor Wormald, and that's basically the anterior approach. He, of course, called it the axillary flap technique. I just call it the axillary technique because for most of us, this is again the right nostril, this is the middle turbinate, this is the septum, that's the lateral nasal wall, and this is what's called the axilla, the part where the middle turbinate attaches up here, and this is the agar nasi. The axillary approach works on the fact that you open or address the frontal recess from anteriorly. So what am I doing? With the microdebrider blade, I am now removing the anterior wall of the axilla. The technique that Professor Wormald had encouraged was he used to raise a flap from here and reflect it here, and it used to lie medial to the middle turbinate. And the basis of that was that once he finished doing all this bony work here, he was able to repose that flap here. In our opinion, or in my experience, I would say, I've not been very, very good with this axillary flap. I just make sure that when I finish the surgery here, there are no bone chips left behind, and this mucosa is still there, which I can just repose. But I'm not very comfortable by raising that flap. And what you have at the end over here now is this big agar nasi, which you've exposed, and you will follow the drainage pathway and open the frontal sinus. So that was the second way of identifying it. Now, why is it that I insist that you should do the ethmoidectomy first? Is because this structure, which we are all petrified of when we start out doing frontal sinus surgery, you're able to identify it right in the beginning. So you know where it is, you've got it out of your way, and you're very, very comfortable. The most important thing is you're operating in an area which is in an angle. You need your instruments to go in. If you remember in the first slides, one of the first slides, I showed you a 90-degree instrument. Now a 90-degree instrument has a belly. And if I've kept the, the ethmoid cells in place, this instrument will not be able to rest. So one of the reasons why you complete the ethmoidectomy first is, one, anatomically you've identified those structures which one is a little wary about. And secondly, doing the ethmoidectomy makes instrumentation much easier when you're working with an angled scope and with angled instruments. So that's why I always believe you should finish the ethmoidectomy after this. Now this is just to show you, this is now the right frontal sinus. We've started, I've finished the entire ethmoidectomy. This is the skull base that we've now defined. Come anteriorly, we've been able to identify where the anterior ethmoidal artery was. I'm removing a couple more cells. I'm quite comfortable using punches in this area. And now with suctions, I'm probing and trying to find where the frontal is. And I've got a good marker here in the form of mucin. So this is the supraorbital cell here. And that where my suction is going in with that mucin over here is the frontal. So supraorbital down there, frontal up there, anterior ethmoidal artery here. So identifying the skull base gave me this structure right in the beginning. I know now I can safely work anterior to that. I was first able to identify the superorbital cell. The mucin gave me an idea as to where the frontal is, and then I've gradually removed all this mucosa. Now the important thing here is this mucosa has to be left intact. If we debride all this mucosa, believe me, some other surgeon is going to get to do a modified endoscopic laptop because there's going to be a load amount of new osteogenesis that's going to be caused there. Now, if you saw it, I feel that in frontal sinus surgery, because this is there for all surgeries, but in frontal sinus surgery especially, feeling, tactile is much more important than what we can see. Because of the fact that you're working with angled scopes and angled instruments, sometimes you're not really able to see as well as feel. So develop that tactile sense whereby you get the feeling that this instrument is just passing into a cavity or a sinus opening. What is the amount of force you should use? And this is something that you will develop over experience. The three things that one has to do with frontal sinus surgery is feel it, fracture the wall, and automatically break the wall. So what used to be originally called as uncapping, I call it as the 3 Fs: feel, fracture, and break or make the wall fall. So this is another one where I'm going to be showing you this. This is an agar that we opened, and I have a drainage pathway which is now, this is in the left nostril, drainage pathway which was lateral to that thing. We broke the cell, and then when I'm looking forward, I'm seeing a cell here, and I'm just going to pause it here and just take it a little back. And most of us might end up feeling that, oh, this is the frontal sinus. The frontal sinus never looks like it has a roof. It is a cavity. The minute I see a cell where I can see an end to it, I know I'm not in the frontal sinus. This is most probably a Kun3 cell. So we then further fracture the wall, which is, pass it into the drainage pathway, feel that area, fracture it, remove all these things. And what you saw me using just now was a giraffe forceps. And now you can maybe see the difference. That's the frontal sinus. So the frontal sinus is the one which is literally a huge cavity with a roof which is almost not seen. You'll see a posterior bulge and you see septate. So this was the cell that I would have thought was the frontal, but actually the frontal sinus drainage pathway was more lateral, was more medial to that. And that's what the picture was right at the end. So again, I knew that also because I had radiology with me. But just to give you that tip as to, and we can show that again, look at this. This is not the frontal, this is the Kun3, and this is the frontal sinus. So this is what I meant by feel, fracture, and fall. So this is what you do very often in frontal sinus surgery. So how do you confirm? Are you really in the frontal sinus, or are you in a supraorbital cell, or are you in a Kun3? And the things, of course, that you can use are transillumination. There was something that was promoted by Nick Jones, which is called the suction probe length. You put in your Kun seeker into that cell, took it out, put it along the lateral wall of the nose, and saw where it went. And that used to give you an idea. As I showed you in that clipping, the roof of the frontal sinus always has septae, and the posterior wall will curve anteriorly. And if you're really, really lost and in a revision case, trephining is something that all of us should have in our surgical armamentarium. So again, we'll just quickly show you this. This is just to show you what the sinus will look like, just to revise what I mentioned about the fact that the posterior wall bulges and the fact that they are septae. This is an instrument which is going there to see. We'll just quickly forward it from point of view of time. And this is what I meant. So you have the posterior wall which bulges, and you have that cavity with septae up there. So you know you are in the frontal sinus when you see something like this. If you don't see something like this, then believe me, you're most probably either in a supraorbital cell or maybe even in a frontal bular cell or a Kun3. And that, of course, the radiology is going to give you idea. What are your limits for frontal recess dissection when you're doing just a frontal sinusotomy? You will have the lamina papyracea medially. You'll have the anterior ethmoidal artery posteriorly, the middle turbinate laterally, and the nasofrontal beak anteriorly. So this would be what you would do when you complete removing all your frontal ethmoidal cells. These are the structures that you should have visible to know that you have done a complete dissection. The surgical tips that one can use, remember always that the endoscope is placed above the instrument, not this. The movement of the instrument should always be posterior to anterior and medial to lateral. If you can remember this, believe me, the structures posteriorly would be the anterior ethmoidal artery, and medially would be the skull base, depending on what Keros classification it shows you. This movement would by and large protect you from causing any inadvertent issues. It's more tactile than visual. And in most patients, if you really want to do frontal sinus surgery, our normal position of keeping that 15 degrees elevation does not work. You have to give these patients an extension of the neck. You have to invariably keep a shoulder support for them and extend that head with a slight head low. The frontal sinus becomes much easier. So especially the fact that most of us will be using angle scopes, you're going to be using maybe punches, etc. You need to create that space here for the instrumentation also. So for frontal sinus surgery, one has to change the position, and that's why, again, finish the rest of the work, come back to the sinus at the end, because then you can give that position and do your work a lot more easily. The surgical pearls for doing good, or I would say adequate frontal sinus surgeries, you definitely need a dry surgical field. This is not the surgery you can do in a patient whose aspirin has not been withdrawn, he's on blood thinners. Just go back and give this patient another surgical date and say, look, I'll do the job maybe a second time. Like I said, identify the recess area, but continue after identifying the skull base posteriorly. In my hands, I found it much easier. My confidence levels have gone up much, much more when I started doing it this way. Try and identify the medial orbital wall. We do that all when we do the ethmoidectomy part of it. Stay close to it, proceeding superiorly. If you're lost, that too helps you very good as an anatomical landmark. Always open cells immediately posterior to the axilla of the middle turbinate. There's nothing else that will come there. There will be an agar maybe, even if it's small or big, you'll be a little more comfortable. So if you're getting lost, use these things, find the medial orbital wall, just work below the axilla of the middle turbinate. Have that armamentarium of instruments that I mentioned, especially the seekers. They are very, very good to identify mucin. And look for pointers. In a diseased frontal sinus, they're always there. You saw me using mucin as a guider to find the frontal sinus in one case. I'll show you one more clipping here. And always, always preserve the mucosa. This is just to show you how a polyp actually led me. You had this polyp hanging here. The minute I removed that polyp, I knew that it sort of gave me a thing that, oh, there you are. That's the frontal sinus. Gave a little wash. This is that malleable suction that I was talking to you about. And now you are in the frontal sinus. We've got to, of course, polish off all this, wash out all this. And that's how I was able to identify the frontal. So look for these little markers. They will invariably help you to find an opening. Post-operative care, 1 week later, the patient has to be taken up for a nasal endoscopy. You remove all that fibrin and blood from the frontal recess area. You've got to make it a habit to do this, because otherwise this is going to form crusting and that creates issues.
Ma'am, your mic is muted. Yeah, ma'am.
Yeah. Should I finish, Vijay? I have 2 more slides, or?
Yes, ma'am.
No, I don't know. This thing just came on by itself.
No, you may have to share the screen again.
Oh.
It got, actually your voice stopped. Actually.
No, it itself happened. So, okay, anyway. So, like I said, this is a good thing. The only thing is, it's not just enough giving the nasal wash, but the patient should stay in that position for about 2 or 3 minutes. It actually helps, especially the steroid things like Budacort, staying in that frontal recess area and reduces the edema. Trephination, just quickly, one must know it. It should be added to your armamentarium. For lack of time, I'm not really talking about it, but this is something that all people who want to work with frontal sinus should know how to do a trephining. Balloon sinuplasty, just to complete the talk, I personally have not done much, but this is again a good instrument to have in your OT, just in case one is really lost, one can have this. I have a video, thanks to Nishit, given to me quite some years back actually, where they have 3 openings here. They really don't know which one is the frontal sinus. You see them using the balloon in this for identifying and dilating the opening. So a balloon sinuplasty, especially I would say in revision cases, works. However, today now with image guided surgery, maybe its role as a guide is not as much, but again, this is something that one can have in the OT and it would help us. There are certain limitations to frontal sinus surgery with an endoscope. However, a disclaimer, this is entirely based on the experience of the surgeon. So there are surgeons who are very comfortable with removing pathologies like an osteoma, inverted papilloma, fibrous dysplasia. So I thereby say it's a relative contraindication. You as a surgeon know your limitations better than anyone else. However, trauma with a distorted frontal recess, type 4 cells, a very laterally based frontal sinus lesions, by and large, I would say, are limited by the fact that we don't have instrumentation that can reach there. Complications, surgical failure, CSF leaks or vital, vascular. These three are because of the anatomical proximity of the structures related to the frontal sinus. This is one sinus which is unforgiving. So unlike surgery on the other sinuses where immediate complications will come immediately, frontal sinus surgery, the patient will come back to you maybe after a couple of years with delayed complications. So keep that in mind. It has a very slow and gradual learning curve, and be ready to just go slowly and improve your surgical skills as you go on. The rule I feel for frontal sinus surgery is it's better to miss, come back another day than create a mess, because that mess is going to be something that you're going to live with for quite some time. Thank you so much. And I'm sorry for going a little over the time.
Thank you, Neelam, for such a lovely talk on and very lucid explanation of the entire enigma of the frontal sinus. This is one of the sinuses which eludes all of us, and I think you brought it out very lucidly, explaining all the various anatomical aspects and what all do's and don'ts which are required to be taken care while performing this surgery. The questions, of course, we have, but I'll get those questions to you later on in the once we end the webinar today. And thank you very much, Neelam. Thanks you for the lovely talk. So we move over to the next speaker today. The next speaker is Dr. Nishit J. Shah. And of course, Dr. Nishit Shah doesn't require any introduction. He's a very well-known figure. He's an honorary consultant in ENT and skull-based surgery in the Bombay Hospital and the Medical Research Center. He's also consultant ENT surgery at the Brig Hospital, Mumbai. And he is well known as one of the past presidents of the All India Rhinology Society. He's been the chairman of the division of skull-based surgery in Indian Academy of Otolaryngology Head Neck Surgery. And he's also been DNB National Board examiner. And he is an avid skull-based surgeon. He operates with his team of neurosurgeons. He's kind of performed more than 2,000 endoscopic skull-based and pituitary surgeries. He has also authored a lot of books. He has a lot of publications to his credit. One of the textbooks is Essentials of ENT Examinations and Principles of Treatment, and a step-by-step endoscopic repair of CSF Rhinorrhea. Also a practical guide to endoscopic transsphenoidal surgery. So these are some of his achievements, and many of us have had the fortune of having to attend many of his workshops, which he holds annually in the Mumbai hospital on skull base and how to do an efficient teamwork. And he is going to be talking today, giving a talk to us on extended endoscopic transsphenoidal surgery. Dr. Nishit Shah, over to you.
Thank you, Professor Dr. Ramakrishnan. Okay. So thank you to the Indian Academy again for this kind invitation to speak to everyone. So this is actually a photograph of Dr. Devpujari and me. Unfortunately, in these COVID times, we are forced to sort of do this over-prepping. We are using PAPRs to do skull-based surgery because at times we feel, even though we don't want to, we are at times forced to use a drill or other aerosol creating instruments. Right. So when we talk of, or when we look at anything new, there's always these steps that sort of it follows. You know, initially there is a lot of skepticism. People are criticizing it. Then it comes a stage where they're saying, don't do it. You must not do it. This is a terrible idea. At some point, it then says, okay, those people who are doing it, let them kind of do it, but I will not do it. And at some point, it then becomes a passive acceptance that, okay, maybe it's not a bad idea. Maybe if you learn it, you can do it. Before it finally gains an active acceptance by everyone. And this often involves long years of sort of presentations and paper writing by the innovators. And that then enables other people to acquire the skills and get good results. So unlike everything else, skull-based surgery also went through these steps before we really got to where we are. So extended endoscopic transsphenoid surgery, basically because skull-based surgery is so vast, we can only cover a little bit today in half an hour. So this would involve a transplanum, tubercular, transcellular, clival, cavernous, and transpterygoid. These are the various approaches you can go through with a transsphenoid surgery. Unfortunately, today, the most basic thing, transcellular, we will not be discussing, but we will try and cover the other approaches. Prior to starting on the approach itself, let's just have a quick view of the anatomy involved. So this is the supracellular anatomy, as you would see it with a transtubercular or transplanum approach. So this is post removal of tumor. You see the optic nerves and the chiasm. You see the anterior cerebral arteries and the anterior cranial fossa. You see the intracranial part of the internal carotid artery and its relation with the optic nerve. In the center here is the pituitary stalk. And if you look carefully, you'll actually see the anterior hypophyseal artery as it leaves the carotid and then to give off branches to the chiasm and to the stalk. So this then represents a really important artery. And when you're doing this kind of supracellular surgery, it's vital to sort of preserve all these separate branches of the artery. And you're not looking only at anterior cerebral or the carotid artery. So again, a cadaver dissection just to show the same view. You have the carotid laterally in its clival, cavernous, and clinoidal sections. The pituitary gland over here, the stalk, and above the stalk, the optic nerves, the chiasm, and the anterior hypophyseal arteries. You'll have the interfascial ligament anteriorly, and then you have the gyrus above. This is another dissection we did in a workshop in 14. We've done a hemiclyvectomy here. This we did with Amin. Vertebrobasilar artery junction, the ICA, which will go off towards the internal auditory meatus. And the back, you have the pons and the brainstem, the medulla. If you look up, the basilar will then divide into four, essentially the superior cerebellar artery and the posterior cerebral artery. And this will happen on both sides. And the third nerve will run between the two, emerging from the brainstem, going behind the carotid in the lateral cavernous and ending up in the superior orbital fissure. Again, you see the anterior hypophyseals, the chiasm, the optic nerves, the anterior cerebrals, and the takeoff of the ophthalmic from the carotid artery. Finally, with a full clivectomy, this is the dissection we did in 15 at, again, one of our workshops to show you the lowermost anatomy. So 6th nerve, the 5th cranial nerves, 7, 8, and then you have 9, 10, 11, and 12. This is using an angled telescope so that you're looking really way down at the brainstem and the foramen magnum area almost. And as you come up again, you will see the internal jugular foramen with the lower cranial nerves will enter, and 7 and 8 entering the internal auditory meatus. So these are the kind of views that you can get when you're doing endoscopic transsphenoidal, transclival surgery. Right, so coming to a more clinical aspect, there are two scan options, a CT scan and an MRI. Always we would do both. The CT scan is important in terms of assessing the septum, the deviations of the septum, any abnormalities or infections in the sinuses, any variations of the turbinates, whether there's a large concha bullosa, etc. The sphenoid pneumatization, you know, there are various types, from a conchal to a cellar to a pre-cellar and a post-cellar. And often you would find that the intersphenoid septum deviates onto the carotid or the optic. So the CT scan really is an ENT surgeon's roadmap, a guide to get to the tumor. And it is essential that you look at all these things. In the tumor area itself, you want to look at bone erosions at any site. If there's any calcification within the tumor, which you may get in a cranio and varying calcification and meningioma. And then, of course, you can do a CT angio, which will then assist you with a navigation protocol, because often you don't see the tumor very well on CT. But if you combine it with a CT angio, then you get a little bit of tumor with the blood vessels, and that's useful if you're using navigation. MRI, of course, is the gold standard for intracranial pathology, and you cannot do any of these surgeries, extended surgeries, without an MRI. So to learn the morphology of the tumor, its size and location, whether it is cystic, solid, what are the relations of the vessels and the nerves with the tumor, where is the pituitary gland, and is there a normal pituitary gland different from the lesion? Is there a dural involvement? So all these situations or all these factors are very important and assessed on an MRI. You can do an MR angio again if you're going to use navigation, and that will give you both tumor and blood vessels to look at. Common pathologies that we deal with in this area are, of course, the pituitary glands and tumors of the pituitary gland, Rathke's cleft cyst, hypophysitis and different types of hypophysitis, craniopharyngiomas, meningiomas, gliomas, chordomas, and other such tumors. So before we actually go into surgery, what are the considerations? One is location. Where is it in the coronal and sagittal plane? So how anterior is it in terms of sagittal? Is it very much on the planum or very inferiorly going on to lower clivus or C1, C2? And coronal plane, when we talk of, we're talking of lateral extension. So is it involving the carotid? Is it going lateral to the carotid? And these are going to be important aspects. Is it going lateral to the optic nerves? So these are going to be important considerations before you decide on which route of surgery you're going to use. Involvement of vessels and nerves. So is the tumor extradural or intradural? An intradural tumor will signify a more complex surgery, as will a malignant tumor compared to a benign tumor. What is the skill of the surgeon, and is he equipped to handle all these situations, or would he rather stay at a cellar level? And of course, most important is that you have to discuss this with the patient. It's not that you're predominantly in favor of endoscopy or predominantly in favor of transsphenoidal. You must have a good balance and then put forward both advantages, disadvantages to the patient, and let there be a sort of a uniform or a consensual decision as to the approach. So once all these things have been discussed, the plan is, of course, has to be made. And you would then follow the plan with a backup plan as well. When you start working as a team, and I would insist that all skull-based surgery be done as a team with ENT, neurosurgery, and the support of anesthetists, intensivists, endocrinologists, etc. When you start working as a team, when you're doing binostril, two surgeon forehand, often there is a clash of instruments because you're not used to working together. Everyone sort of wants to get his instrument in or doesn't know how to move out of the way. So avoid frustration. It does take a little time, but over time, especially if you work as a team, you find that things get smoother. Have a good exposure, and that will help you get things better. Have the right equipment. Again, the right instrument will avoid a clash. CSF reconstruction was the pillar, was the cornerstone of skull-based surgery. And the reason why it took a little longer time for neurosurgeons to accept that you could do these surgeries nasally or endoscopically, because initial CSF failure rates were around 30–40%. So if you don't have a good CSF reconstruction ability, then you're not going to get very far ahead with this. And again, probably the most important statement that one can make in this is that when you get intracranially, it looks spectacular. It looks very nice when you have these nerves and vessels and tumor and everything there. But it is more important to know when to stop than when to continue. All surgery must be done with a view to limit morbidity and complications, because in the skull base, complications are not minor. These are major complications which will stay with the patient for a long time. So take joint decisions and decide when it's important to stop. This will of course depend on tumor pathology, benign, malignant, etc. 4 different stages that all skull base surgery, endonasal surgery follows is the nasal stage, sphenoidal stage, intracranial stage or tumor removal stage, and then the reconstruction stage. Right, so we always use a binostril approach. It's always 2 surgeons, 4 hands. More often than not, we'll need a Haddad flap because extended approaches almost always will have the potential of a CSF leak. Wide exposure is one of the keys to do this. And for that, often we need to open up the posterior ethmoid or the maxillary sinus or have a good view of the nasopharynx to be able to achieve these things. For CSF reconstruction, these are the various techniques that we can use. A vascularized pedicle flap is the most important aspect, but we also take advantage of these other things. So one must remember that when you use a Haddad flap, you're going to sort of layer it to the back, and the length of that flap will depend on the pneumatization of the sphenoid and the site of the defect. So a suprasellar or planum defect requires a longer flap than a clival defect, and a well-pneumatized sphenoid will require a longer flap as compared to a presellar. So let's look at a few surgeries. We'll start with transtubercular. This was a craniopharyngioma. I'll let you look at the scans. So this is a cellar, and you can see that's the tuberculum. And so we need to take, we don't need to do too much on the planum. We just do a transtubercular. Now, generally speaking, when we are doing pituitary surgery, we tend not to do a Haddad flap. We do only rescue flaps, which are incomplete Haddad flaps. We also try and preserve all the turbinates. When we are doing extended surgery, almost always we'll do a Haddad flap, and usually we take off the middle turbinate on the right side because that is a side which has more instrumentations and will be a little more difficult to handle. So we start off with the Haddad flap, and important again when you're doing superior or suprasellar issues is to come as anterior as possible. Come right up to the mucocutaneous junction. Do not stop short. On the opposite side, we do what we call a reverse flap. So this flap is, of course, the horizontal incisions are the same as the rescue flaps up to the cartilage bone junction. But posteriorly, you take a vertical incision across the face of the sphenoid, leaving it pedicled anteriorly. The advantage of this is, as you see, it comes into the Haddad side flap and covers the bare cartilage so that you have minimum crusting and the recovery is quick. You don't have to see the patient very often in the post-op stage. You do need that large posterior septectomy. So instead of wasting this mucosa, you would then utilize it. The Haddad flap is tucked into the nasopharynx, and then you can go ahead with opening up the sphenoid wide. Now, to do any transplanum surgery, you have to take the inferior parts of the superior turbinates and open up the posterior ethmoids. Because if you don't open up the posterior ethmoids, you don't have one, a good view of the planum, and two, a good working space. 3, you also need a place for the endoscope to sit so that the surgeons can work together. So you see already now we have 2 surgeon forehand in. The third hand is using irrigation. We prefer freehand endoscopy and manual irrigation. And once we've opened up these from sella to the tuberculum, we can then take our incision on the dura. Once we've done that, of course, I can go a little quicker now. We open up the craniopharyngioma and we can sort of decompress the internal of the craniopharyngioma. You want the walls of the craniopharyngioma to collapse easily. And so you want to decompress the internal as much as possible. We then try and find a plane with the cyst wall and the surrounding. And cranios can be tricky because sometimes you can get a very easy elevation from the sides. And sometimes the wall can be very adherent to the carotid, to the branches, to perforators, and to the optic nerve. And it requires then very, very careful dissection to free it from them without causing a problem. If it is adherent to the hypothalamus, then you have to leave behind some parts of it. As concerns the stalk of the pituitary, there is a divided opinion on whether to sacrifice the stalk and remove the gland, the cranio completely, or try and preserve the stalk. So once the cranio is completely excised, we then have a small hole, a couple of holes there in the arachnoid. And the way we're going to stock this is one, I'm going to plug those two holes there. So we already have some control over the leak. We then put some fat in and then underlay fascia. You can even use a piece of Duragen, for example, for this part. And then on top of that, we would come the flap. So it's important to note that there is no intervening tissue between flap and bone. So you don't want Surgicel or fascia as an overlay. You want the flap to sit on the bone. So we come next to a meningioma. This is now a transplanum approach. You see it's coming comfortably onto the planum, more or less towards the right side, involving a little bit of the carotid and the optic nerve. So the initial steps are the same, which is of taking the flap, the reverse flap, and we can skip all that. And we can come straight to the sphenoid itself. Now you see here, the middle turbinate is gone, the superior turbinates are gone on both sides. And we have this very nice exposure all the way from the back of the posterior ethmoid to the clivus. And it's important to get this view. Even laterally, you must have a good view of the orbital apex and the carotids, so that you can see clearly the optic nerves and the carotid in its entirety before you start drilling. Once you are satisfied with that, of course, you remove the intrasphenoid septations. You have a clean, smooth field, because when you put the flap, you don't want serrations or partitions. Also, you want to remove all the mucosa so that your flap sits on bone. You then notice that the bone, sometimes the meningioma gets a little thicker and the dura is a little more granular. And this is quite typical of a meningioma. And the below part is a normal pituitary gland, which you can see here, which you have to, of course, be careful about, but you try and define it so that you know where the bottom of the meningioma is. Laterally will come the optic nerves. That's the carotid. So once you have a good exposure done, you then need to open it up. You need to deal with the let me go back a second. You need to deal with the intercavernous. So the intercavernous, the superior intercavernous will run across at the level of the tuberculum. And you need to cauterize that before you sort of get in. You can then open it up and start defining the edges of the meningioma. You see already the perforators and the optic nerve behind. And gently you sort of dissect the meningioma from the surrounding tissue. It is not necessary when you're doing cranial skull-based surgery to do an en bloc resection. Almost always we'll remove it piecemeal, and it is often safer to remove it piecemeal, because if you try and remove it en bloc, you don't know what you're pulling on. If it is attached to something, which is attached to something, which is then attached to an important vessel. So always remove in pieces so that you can keep seeing what lies beyond it. So as we go further back, you see more of the nerve and you see more of the tumor being gradually removed. So again, I can go a little quicker here. And we'll remove a little more bone now as we come towards the optic. You see how we are removing it in piecemeal. So we're removing pieces so that it becomes easier for us to remove tumor without having any neurovascular injury. And as we come towards the last part of that meningioma, you start seeing the right optic nerve now and the chiasm. So we'll finish off with a little bit of dissection of that optic canal, ensure there's no tumor remaining in that area. And then of course will come the main thing of reconstruction. So that's our completed field, stalk, pituitary gland, optic chiasms, anterior cerebrals, and the whole defect. So it's not that we follow the same reconstruction in every patient. Every patient is different. Our pressures are different. Our exposures are different. And so the reconstructions are often different. This is what we did for this patient. So we used fat for internal. And then I used a large piece of bone. This is the anterior wall of the sphenoid, which we are using to sort of impact it. And if you use bone, it is important that this piece of bone is the right size. You cannot have a bone smaller than the size of the defect. And you cannot have a sort of combination, a jigsaw puzzle of 3 bone pieces to put and make a bone barrier. Because if those pieces move individually, then over time with the pressure, it'll knock the opening out and it'll leak. So your common sources of this bone are your septum, of course. You can use cartilage or bone, anterior wall of sphenoid, and intersphenoid septations. So once we had the bone in place, we then did a little bit of cheating. We put a little bit of fat at the bottom. And what that allows me to do is to move my flap, not have to go all the way back to the clivus, but I can run the flap on the fat, and that allows me to get an extra length. So I can cover easily the planum without the flap falling short. So these are small tricks that you learn as you go ahead. You always want the flap to rest on a structure, and that rest should not be at the area of reconstruction. Right, so just a word on a meningioma is that there is still a lot of controversy. There is divided opinion on whether to go transcranial or endoscopic. And the decision at the moment seems that it's a good idea if there's a good case selection and an experienced team of surgeons. Important areas when you're doing skull-based surgery is to have a navigation system, a Doppler, the right instruments, the ability to stop bleeding, and to do a good repair. So coronal plane, this was a tumor which involved the carotid. I'm going to go straight forward. So a regular dissection, exposure, very lateral. This is the internal carotid artery. And you can see now how we are removing tumor lateral to the carotid. So when we talk of removing tumor in the cavernous, you're not really playing with the carotid. You can go either side of the carotid and you can work around, but you should not move the carotid around too much because there is a potential for a spasm. Right, so this is just the end view now of the carotid and the pituitary dissection with the carotid. You must have a Doppler when you're doing this kind of surgery, essential. If you go a little more lateral, now this is a chordoma, which is entirely lateral to the carotid artery. So for this, we need to do a transpterygoid. So you see the maxilla has been exposed here. The sphenoid has been exposed at the back, and we are going to knock off a large part of that pterygoid process so that we can get lateral. So to get very lateral, that's the median nerve, we will have to go transmaxillary or transpterygoid and get a good exposure in that side. So there's a lot of drilling that is involved to get that kind of exposure. And at the same time, you must also have a good view and understanding of where the foramen rotundum is, where the orbital apex is, where the optic nerve is going to come. So you have in this case a large onode cell where you have the optic nerve running. You're taking the mucosa off the lesion here, lateral to the carotid. And there's a small intrasphenoid septation which lands or ends up exactly on the carotid. So that needs to be drilled as well prior to tumor removal. So you see the optic nerve running in the onode, and we remove that partition between the sphenoid and the posterior ethmoid. Last bit of bone removal work, and now we are sort of have a good view of where the carotid will be, where the optic will be. We'll confirm with a navigation as to all these structures. Final bit of dissection around the median nerve and around the bone on the carotid. So once all that is done, we can then check with a Doppler as to the position of the carotid, which is what is happening now, and then open up the dura. So the chordoma can then be removed in a safe and effective way. This is flushing the cavity. This actually we were doing during one of our workshops with Professor Locatelli, who works with Paolo Castelnuovo in Italy. And they have this technique of diving where they submerge the cavity with saline, and it helps flush out things and also allows you to see things clearly. So now you'll see the carotid artery in its medial aspect of the lesion. And you can even actually see the atherosclerosis within the carotid artery. So fortunately, this chordoma was entirely extradural. We didn't have a CSF leak, but with an exposed carotid, always safer to cover it with a flap so that there is no issue of danger to the carotid later. Right, so very quickly, let's go to the clivus. So now we are going inferiorly. Clivus is divided into upper, middle, and lower. Upper part relevant anatomy is nerve anatomy is third nerve with the upper, 6, 7, 8 with the middle, and the lower cranial nerves with the lower clivus. To expose the upper clivus is basically just under the sella. It's the sort of cradle that holds the pituitary, and you can open it up by removing this part of the bone. To remove middle or lower clivus, we then take an inverted U-shaped incision and work medial to both the eustachian tubes and then remove bone in that area inferiorly. So let's look at a clival meningioma here. Quite a large thing, extending to the lower clivus. Initially, of course, the incision is the same. We do a Haddad flap. I'm going to bypass that. Middle turbinate is taken. And the maxilla, the difference is that the maxilla is opened because the Haddad flap has to be tucked into the maxilla. You cannot keep it in the nasopharynx because you're going to work in the nasopharynx. So open one side maxilla and tuck your, of course, the side of your flap, and tuck the flap into the maxilla. And then basically I want to show you how we do the pharyngeal flap. So we disconnect the posterior end of the septum, take high incisions just on the basis sphenoid, and these incisions will run vertically down medial to the eustachian and the just sort of at that fossa of Rosenmüller area. The mucoperiosteum is then elevated of the basis sphenoid, and this requires a little sort of sharp dissection, and we use a monopolar needle cautery, or what was called a Colorado needle, to elevate this. The depth or the inferior level of this flap will depend on the lesion, and it can be confirmed easily by using a navigation. So as you can see, we are taking this entire U-shaped, inverted U-shaped pharyngeal flap down, and this will then come back with the Haddad flap to close the defect. We then remove the floor of the sphenoid, remove the clivus itself, and you can see a lot of bone work is required. A lot of this bone has to be removed, and you can see that in the post-op scan. See the amount of bone that has gone from here, right? So a lot of bone work. Clival surgery requires at least 70% or 75% of the time is an exposure as against tumor removal. Once all the bone work is done, then you come down to the tumor, and you can incise the periosteum, the dura, and start removing tumor. Again, you want to start, generally you can start from bottom or from the top. It depends on how you want to work, but try and find an edge, stay in the center, and then work towards the periphery. In the center, you have to watch for the basilar artery, and again, your Doppler and your understanding of the vessel, whether it lies on right or the left or the midline, is important. So now you see that the basilar is coming to view, and the tumor has to be carefully dissected from the basilar until it is completely out. So once it's all clear, we reconstructed this with fat as an initial layer, and you need to put in a lot of fat because there is so much of a dead space which you need to fill. My pharyngeal flap came back up. I then put in an underlay fascia and then some more fat because you want to bring it to the level which it was initially. And then finally you can put your Hadad flap in. And our last case will be this chordoma. Again, this is a very, very low chordoma, as you can see. Entire clivus going into C1. Pretty much the same, all the procedures. Inferiorly take the flap, take out all the bone work, expose the clivus, and then start removing tumor. So as you remove tumor, you will see the arteries at the back. You see the pons and the brainstem below that. So you see the basilar, the pons, and of course you have some more tumor here at the bottom. This is the division of the basilar and the pons at the back. And as we go inferiorly and remove this, you see already nerves, lower cranial nerves coming into view here, and 7 and 8 here. So it does require some amount of training, experience, and years of working together before you can sort of remove tumor at this area, that's the medulla below, safely and attain a good result. Reconstruction with, again, similar like we did in the earlier case, fat and using both our flaps with fascia. Right. So just like to say thank you again. We did publish or release this book in the beginning of the year. It's basically on transsphenoidal surgery. We were very fortunate to have both Ricardo and Amin write the forwards, and most of what the work we do have been learnt from Ricardo and Amin, and we are very grateful to them for their help, as well as the entire neurosurgery department and all the neurosurgeons. I work with, I think, about 10, 11 neurosurgeons at Bombay Hospital, and at least 2 or 3 outside of Bombay Hospital. So I'm very grateful to all of them for their support in doing this kind of surgery. And finally, thanks again to the Indian Academy for their invitation. Thank you.
Thank you, Dr. Nishit Shah, for such a lovely disposition of the endoscopic skull-based surgery and its expanded usage. I'm sure there are a lot of questions on this because not many people are venturing into this territory, and for want of expertise, and so also want for a requisite teamwork, which is there with you. And thank you very much for such a lovely talk. And the questions we'll address you towards the end.
Sure. Thank
you very much. So our next speaker is going to be Professor Prepageran Narayanan. He's Professor of ENT and Head and Neck Surgery from the University of Malaya, Kuala Lumpur, Malaysia. He's done his FRCS from Glasgow, and also his US MLE Fellowship in Neurotology and Otology from Canada. He's also the president of the 9th World Congress on Endoscopic Surgery and Skull-Base, Brain and Spine. He is also in the National Network Advisory Board International for Global Cochlear Implant Access. And so also he's in the International Advisory Board of the ASEAN Oral 2017 group. And he's also in the International Advisory Committee Board for the World Scientific Education Committee member on Rhinology World 2017. He's got a whole big list of achievements. I won't waste too much of time in him. And we have heard him many times in various conferences in India, in various, I'm sure many people have learned from him a lot. And his specialty is basically in neurotology, and so also in endoscopic sinus surgery. Now, one of the main issues about which people are concerned about, the operating surgeons are, is the issue about bleeding. And today he's going to be deliberating on that very issue. And I request him to kindly take over, and he will be basically talking on the intraoperative management of bleeding in the endoscopic sinus surgery. So over to Dr. Prepageran Narayan.
Thank you, Mr. Chairman. Thank you very much for the very kind invitation. Let me start by, let me play with my screen. So I'd like to thank the Indian Academy for the very kind invitation to give the talk today. So I'm going to be speaking about endoscopic management of intraoperative bleeding. So let's start first of all with a very quick overview of the blood supply itself. Here, when we decompress the orbit, you can see the anteroethmoidal artery coming between the superior oblique as well, and the middle vectors going into the intraoccipital cavity. And this is the posterior ethmoidal artery. So that is the anteroethmoidal artery, posterior ethmoidal artery. And this explains why an injury here would cause the artery to retract into the orbit itself. And if you follow the orbit like an ice cream cone, it takes us straight to the optic nerve, and then there's a carotid artery, and there's a cavernous sinus. It's another dissection of the infratemporal fossa. It shows us the maxillary artery and how the infraorbital nerve, the maxillary artery, and that's the descending palatine, as you can see. The maxillary artery, after the descending palatine branch, becomes the sphenopalatine artery. And these are the branches of the maxillary artery with a branch that's following the infraorbital nerve as well. This is the infraorbital artery. So this is a dissection that I did in Bangkok for the neurosurgeons. What this shows very nicely, it complements what Nishit has showed very nicely just now. The carotid on the right, carotid on the left. You can also see very clearly the superior hypophyseal arteries on this side. Both on the left side, you can see the superior hypophyseal arteries here. And that is the right optic, left optic, optic chiasma, pituitary stalk. And you can also see the ACAs. But what is more important is this. You can see the superior hypophyseal artery. You can see the inferior hypophyseal artery and on both sides and how they anastomose with each other. So with this, we have given an outlook of the anatomy itself. And obviously, before we do any surgery, we need to make sure preoperatively any medical conditions that requires that patient got aspirin, we have to ask them to stop. In my part of the world, traditional medicine is very common, and quite a lot of the Chinese traditional medicine contains a lot of anti-platelet activity. And for some reason, I find patients who smoke, we can easily identify those who smoke. You can always find that their mucosa is always velvet-like in appearance, and whatever you touch, they tend to bleed very easily as well. So this is the way I do mine. There are always variations. It's good to see how different people do, pick up points from everyone, and come up with the way that you are most comfortable with. We always place the patient head up. I use phenylocaine decongestant nasal spray first, immediately after intubation. Then we use a ribbon gauze adrenaline 1 in 1,000 packing. We pack 2 packs. One is along the floor and one is between the middle turbinate and the septum. This is done blindly, by just blindly before we even scrub. Then we go and scrub. By the time we scrub, we paint, we drape, then it's almost 10 minutes. The entire packing is already there for 10 minutes. Then once the endoscope is there, then we pack the middle meatus itself, or the sphenoethmoidal vessels, depending on what surgery we're going to do. So this is the co-phenylocaine spray that we use, and this works very well for us. And even now when we do local surgeries, we use this as well very comfortably. There are a lot of other methods as well. Some people use TIVA, the total intravenous anesthesia. Some use hypotension. Some use local injections as well, palatine blocks, pre-operative steroid, tranexamic acid. I don't use TIVA, I don't use local injection, I don't use palatine blocks, but these work. So you should see what other surgeons do, pick up tips from everywhere, and then come up with a way that you're most comfortable with that works in your hands. Let's talk about what we can do if we know that the patient is going to have bleeding. What we can do in advance to avoid bleeding So one is a sphenopalatine artery. Number two, obviously, we can always do a maxillary artery clipping and cautery. And this is what I will do for all my angiofibromas. We have stopped embolizing all our angiofibromas unless they are so extensive that the maxillary artery is distorted. As long as I can visualize the maxillary artery, I'll always clip the artery, because we had one patient with a small angiofibroma who lost vision on one side because of embolization. So ever since then, I've stopped embolizing all my angiofibromas. So let's start with the sphenopalatine artery. Yeah? So this is a dissection that I did in Chiang Mai. It's all we need to do is to open up the space a few millimeters just anterior the posterior attachment of the middle turbinate. And you need to go all the way into the bone. If you do not go all the way into the bone, you won't be in the right plane. You must go subperiosteally. And once you're subperiosteally, you can dissect it. It's very important you're subperiosteal. And then as you elevate it upwards subperiosteally, you will identify the sphenopalatine artery. So this is the easiest way to do it. As long as you're subperiosteal, it becomes very, very easy to identify the sphenopalatine artery. And there's no need to remember structures because there is nothing else there. Subperiosteal, a few millimeters from the posterior attachment of middle turbinate, and it goes straight to sphenopalatine artery. One of the examples, I was doing a infratemporal fossa schwannoma, and you can see, again, the middle turbinate, the attachment. As long as you go subperiosteally and you elevate it right from the bone, there's no other structure that will come into view but the sphenopalatine artery. And you can either clip this or cauterize this, but we will just cauterize this. How about internally maxillary artery clipping? So what we need to do is, first of all, is to open up the posterior wall of the maxilla, then remove the fat that comes with it, and then we need to clip. So if we want to stop bleeding in the sinonasal cavity, the clip should always be placed distal to the descending palatine because you want to preserve the blood supply to the palate. Okay, and this is the view after the clipping of the maxillary artery. The clip must go through and through all the way to the end. And you can see there is pulsation proximal to the artery, but there's no pulsation distal. So that's what you want to see before you do the surgery. And after that, I was able to continue to remove the angiofibroma. So in most angiofibromas that go only to midway of the infratemporal fossa, we will not embolize at all. So it's another example of, clipping. This is a patient who's got a revision nasopharyngectomy. Here we can see tumor that is adherent to the IMAX itself. I've dissected that's the infraorbital nerve, as you can see, the temporalis muscle. Here, the tumor it's stuck to the maxillary artery. So what we need to do is first, we need to clip the maxillary artery. And I always use two clips. The first one to stop bleeding. The second one is for luck, just in case the first one slips. And it's very important that the clip goes through and through all the way to the end. So once the clip goes through and through all the way to the end, when we cut the artery itself, it's also important to leave a small cuff of tissue proximal to the clip. If where we cut is too close to the clip will come out on its own. And after this, we were able to dissect and remove the whole thing. So this is another example of someone who's got a CA palate and going into the tegopalatine fossa. And in this case, there was a lot of bleeding. So we needed to clip the sphenopalatine artery. So this is the left maxilla that's been opened up. That is the maxillary artery. I'm using a ball probe to dissect the maxillary artery. Then once we identify the maxillary artery, we can clip the maxillary artery. And in this case, we are going to clip proximal to the descending palatine, as you can see. So I'm going to use, the clips I use are the simple Liga clips, and the clip applicators are the head and neck applicators as well. We don't have any fancy clips to be used or instruments to be used for intranasal. And you can see the clip must go through and through, and you can see the pulsations more to the proximal, and then we can continue with the surgery. So this is the view after the clipping. That is the descending palatine here. It's very important that the clip goes through and through all the way to the back. And again, we clip proximal to the descending palatine if the surgery we are doing or the bleeding is coming more inferiorly. That's the descending palatine before it becomes the sphenopalatine artery. This is an example of a patient who's got an extensive adenoid cystic carcinoma. You can see the patient has got adenosine carcinoma going to the infratemporal fossa, the pterygoid plate. So in this case, we are opening up the posterior wall of maxilla. And once we've opened up the posterior wall of maxilla, we are able to identify the maxillary artery. So we need to dissect the maxillary artery, and the best way to do it, in my opinion, is to use a sickle knife. I work in a public institution, so the sickle knives are always blunt. So you dissect the artery with a sickle knife, and then we clip the maxillary artery with 2 clips, as you can see. With this now, we know that the bleeding that we will have, and the clip must go through and through across the maxillary artery. Now that the artery is been clipped, we know the blood supply to the pterygoid area would now be reduced. And now we can continue our dissection to the infratemporal fossa and remove the malignancy of the infratemporal fossa and clip and drill the entire infratemporal fossa as well. So what do we do when we have an intraoperative bleeding that happens unexpectedly? Now, all of us have this, and all of us have seen this in our career. We can only do advanced surgery if we are able to stop bleeding. So what do we do when this happens? It will happen. Although it's easier said than done, the most important thing is do not panic. Simply because you are the captain of your ship. The minute you panic, the entire operation theater panics in front of you. And it's impossible and it's not human not to panic. You just don't have to show. Pack that area for a while, calm yourself, and get help. No matter how senior you are, how experienced you are, it's always important to get help. Simply because even the junior most resident, all he needs to do is to hold the suction. It's important to have 2 good suctions, locate the bleeder, divert the blood from the area that is bleeding so that you can identify the exact location of the bleeding itself. Only then we will be able to come up with the 3 scenarios. The 3 scenarios are basically very simple. 1 is a shooter. A shooter is probably the best bleeding you can have in endoscopic sinus surgery, as long as it's not a carotid artery bleed. Simply because you know exactly where it's coming from and you can cauterize it very easily. The most difficult bleeding is the mucosal and tumor bleeding. You can pack that area, you can bipolar the area, but until the entire tumor has been completely removed, there will always be bleeding. And it's amazing the amount of blood you can lose from a tumor bleed or oozing because you don't realize how much blood you're losing. If you have bleeding that is surrounded by bone, you use bone wax. And if you have bleeding from the intercavernous sinus, we use bipolar and Surgisan as well. So this is an example of a very old video. I did this surgery many years ago in another hospital. Again, it's an angiofibroma going to the infratemporal fossa. We don't embolize as I mentioned. And I know for the fact now I'm going to start having a shooter from the maxillary artery. So this is an unedited video. So you can see the maxillary artery shooting. So this is probably the best bleeder you can have. Your scope will get dirty, it's fine. Take it out, clean it, put it back inside. Then use a head and neck bipolar. We use a conventional head and neck bipolar. You're able to identify the exact location of the bleeder and then stop the bleeding, as you can see, and continue with the surgery. This is a patient who's got a bleeding from the posterior nasal artery. We are doing a skull-based dissection for this patient. And again, you can easily stop this bleeder by using a monopolar burner. And quite often our bipolars and monopolars don't work. I don't know whether you guys have this problem in India, but quite often ours don't work for some reason. There you go. So I think I just made the bleeder worse. So I think the easiest way to stop this bleeding is to use a bipolar. Sometimes when your monopolar does not work, the more you suck on it, the worse it becomes. And eventually we stopped it. When the bipolar worked, we were able to stop the bleeding quite nicely and then continue with the dissection. That's it. So all the drama just now was simply because the bipolar didn't work. Happens to me very often. I'm not sure whether it happens to you guys in India. This is a patient I'm doing an optic nerve decompression. That optic nerve has been decompressed. You can see a vein that is an abnormal vein that is running under the optic nerve. We can't compress this because if we compress this, the optic nerve will be compressed. So the trick of doing this is you need to cauterize this vessel. At the same time, make sure you don't touch the optic nerve. So how do you do that? By using a bipolar, make the vessel taut. When the vessel is taut, it will be pulled off from the optic nerve. and then you're able to cauterize only the vessel without touching the optic nerve. Again, as you can see, we use simple head and neck bipolars. We do not use any fancy bipolars at all. This is a patient, we're doing another optic nerve decompression. The orbit has been decompressed on the right side. That is the optic nerve that is being exposed here. And you can see the bleeding is coming from the bone. Now, how are we going to stop this bleeding? We cannot pack that area, obviously, because then the optic nerve will be compressed as well. So the best way to do this is go back to the main dictum. Whatever bleeding that comes from the bone, we use a bone wax. So the trick is, when you apply bone wax to the region, we have to make sure we do not use too much bone wax. If we do, we're going to compress the optic nerve. So the trick is to place a small amount of bone wax on the bone. And then when we press the bone wax onto the bone itself, make sure that only a small amount goes in, and then suck away the rest. And with that, the bleeding stops on its own very nicely, as you can see. This is an example of a patient who's got a recurrent skull-based inverted papilloma, skull-based papilloma. What makes the surgery difficult is that the optic nerve, the duras are all dehiscent. And again, the best way to remove these tumors is by using a debrider. I call this a dancing tumor concept. So as long as the tumor dances with you with a debrider, you know that this is stuck. Well, this is not. So this is a dancing tumor concept. A tumor that dances with your debrider is not stuck and easily remove it. So subsequently, you can come to the stalk of the tumor. That's the optic nerve that is dehiscent. That's the carotid artery that is dehiscent, as you can see. So this is the bleeding point. It's probably coming from the outer layer of the carotid artery and optical keratoconus recess. So how do you stop this bleeding? You can just put a piece of Surgicel if you want to, but then the papilloma will come back because this is where it's originating from. So the way I do it is I will use a suction and dissect the mucosa away until you come to a fine point. And then you can cauterize it. And when you cauterize this, you must make sure you do not press into the perineural sheath or the carotid artery. Then again, by using a suction, you can dissect away whatever stalk of the inverted papilloma. And you can see a small, tiny hole just on the ICA here, but this is fine. As long as the tunica adventitia is intact, nothing will happen. This is how it looks like post-op, and you can see everything is healed quite nicely as well. Another example of a surgery is a patient who's got a nasopharyngectomy. We're going to do a nasopharyngectomy for recurrent NPC, and even before surgery itself, I know I'm going to have a nightmare simply because look at the location of the tumor. Is that the petrous apex is eroding into the petrous apex. And this surgery was done around 10 years ago, and I was doing it in another hospital. We did not have a monopolar burner, so I had to use conventional head and neck scissors. And look at the amount of bleeding that you get whenever you do a nasopharyngectomy without a bipolar. Don't panic. Get a colleague to suck the blood away. Now we're going to cut the eustachian tube. It's so much easier to do this with a monopolar. But whenever you are bleeding like this, you just have to divert the blood away, identify the exact location of the bleeder. Sometimes you have to suck between the two bipolar hits, divert the location of the bleeder so that the bipolar can actually identify the bleeding. There, my suction is going between the two bipolar hits. Only then we are able to identify the location of the bleeder and then remove the bipolar so that it can be cauterized very nicely. We drill the petrous apex, and this is the final view. Again, you can see that that is the mucosa, lamina propria, that is the prevertebral fascia at the back with the basilopharyngeal membrane. And here you can see what I said was difficult, simply because at the petrous apex, you can see the carotid artery. That is the horizontal portion of the carotid artery here. And that is the vertical portion of the carotid artery, as you can see, exposed after we drill off. And this is the sphenoid sinus. And we've drilled off medial to the petrous apex as well for this surgery. So a few more videos to show, this is a patient that we're doing an approach laterally to the cavernous sinus region. As we use a Carrison punch, we can see that we had a bleeder. It's probably the posterior nasal artery. This is the best bleeder you can have. You know exactly where it's coming from. You know the amount of blood you're losing, and then you just use a bipolar. We use a conventional head and neck bipolar. We're able to stop the bleeder quite nicely and then continue with the surgery. Another example of a bleeder, I think this is coming from the posterior nasal as well. So again, we can see where the shooter is coming from, identify the exact location, use a simple head and neck bipolar, and then you can cauterize it quite nicely, and the bleeding stops very nicely as well. This is a patient I'm going to do a nasopharyngectomy. We are cutting off the inferior turbinate. That is probably the inferior turbinate branch from the sphenopalatine artery. And then again, you can just use a bipolar and cauterize the exact bleeding point. We use a conventional head and neck bipolar, and then the bleeding point stops very nicely as well. This is a patient that it's an old video, but the intercavernous sinus has got a little bit of oozing. So I'm trying to use bipolar to stop it, and guess what I did? I made it worse. So sometimes the intercavernous sinus, you try to bipolar, you actually make it worse. Now the bleeding is going all the way into the suction. There is bleeding. It's not there's no bleeding, it's all going into the suction. And the more you suck on it, now I've converted a small, tiny spurter into a much more significant bleeding. So to stop bleeding like this, all you need to do is put a Surgicel on top of this, put a patty on top of it, and wait for 10 minutes, and the bleeding will stop. Waiting for 10 minutes for surgeons like us is very difficult. Yeah, it's very difficult for people who are inpatient like us to wait for at least a few minutes with the Surgicel, but you have to. Another video where the intercavernous sinus is bleeding. In this case, we were lucky because there was a bone around it, so we were able to put a Surgicel on top of it, compress, and the bleeding stopped very nicely as well. One of the things that always amazes me until now is the amount of bleeding that you have when you strip a mucosa of the sphenoid sinus. Look at that. A normal sphenoid sinus, you remove the mucosa, the amount of bleeding you will have is quite significant. It can be quite scary when you do it for the first time. Don't panic, just leave it for a while, pack that area. It will stop within a few minutes. This is a patient who's got a meningioma of the skull base. What makes this difficult is if you look at the skull base, the entire bony area here is abnormal bone. Simply because the meningioma takes the blood supply from this particular bone. And as you drill this, you will have significant amount of bleeding. Can you see that, guys? So as you drill this meningioma of the bone to expose the meningioma, you have quite a significant amount of bleeding. So how do you stop this bleeding? The best way to stop the bleeding that's coming from bone in this meningioma is to use a bone wax. How do you use bone wax? I'm sure you have seen your girlfriends or your wives apply foundation on their face. Be generous, make sure it's a nice thin layer. And how do you stop further bleeding? You drill on the bone wax itself. As you drill into the bone wax will be pushed into the sinusoids that come from the bone. And then with this, you can control and make sure there's very little bleeding. Otherwise, you will end up losing too much of blood even before the dura is exposed itself. It's another example of a bleeding from the cavernous sinus. And here you can see, in this case, we were quite fortunate because the bleeding was coming from surrounding the bones. We're using a bone wax to stop the bleeding, as you can see. This is a nice case I would like to show you. This is, you can see there's a tumor in the cavernous sinus itself. And again, to remove this tumor, we have to expose the cavernous sinus. That's the cavernous sinus portion. And you can see the tumor is inside the cavernous sinus itself. So now we're going to remove here on the left, that's a paraclival carotid on the right side, that's the pituitary gland. That's the paraclival carotid on the left side. We're going to remove the bulge or the soft shell that is in front of the cavernous sinus. The patient actually presented with a third nerve palsy. So once we have exposed this dura, here, this is the cavernous sinus that's being exposed. That's the paraclival carotid. So now we know that when we open the cavernous sinus, we're going to have torrential bleeding. If we are lucky, the tumor would have thrombosed the cavernous sinus and you will not have bleeding. So here, the moment of truth. So now, Vicky, my neurosurgeon, is going to open the cavernous sinus. You can see how tough the dura is, a new blade, and how many times you have to make the incision just to open the dura. Yeah. So far, so good. No bleeder. Dura is open. The outer wall of the cavernous sinus is exposed. Now we are going to cut the outer wall of the cavernous sinus. You can see the tumor coming into view. That's the leaflet of the cavernous sinus. No bleeding yet so far. And there you go. So in this case, we were not so lucky. The cavernous sinus was not thrombosed. And you can see the amount of bleeding that you get from the cavernous sinus itself. So what has happened is the tumor was compressing on the cavernous sinus, and the minute the dura was exposed, the compression is over, and then now we have oozing from the cavernous sinus. We stopped this ooze by using some Surgicel. Didn't work very well. The bleeding just continued. So we used some flow seal to finally stop the bleeding, and then we had stopped the bleeding enough for us to continue with the surgery. This will not stop bleeding until the entire tumor is out. And that's the tumor that is being removed from the cavernous sinus, as you can see. So this is, I'm holding this faucet, and now Vicky is dissecting. And as we remove the tumor, the compression over the cavernous sinus is going away, and you get more and more significant bleed. So that is the tumor being dissected out. And as the tumor comes out, can you see the amount of bleeding that you get? Because the compression over the cavernous sinus is gone, you cannot stop the bleeding without removing the tumor. So the tumor is being removed and dissected out. And now with the 4 hands, we're dissecting the tumor from the cavernous sinus all the way from the lateral wall of the cavernous sinus. As you can see, that's the tumor coming out from the cavernous sinus. And that is the lateral wall of the cavernous sinus, and then the tumor has been dissected out. So that shows us the nice view of the cavernous sinus. And obviously we will have bleeding there, and that we stopped by using Surgicel into the cavernous sinus, as you can see, right? Last 2 cases before I finish. This is a patient who just presented with a headache. And if you look at the scans, what is scary is the patient has got a tumor that has eroded the entire petrous apex. That's the carotid artery. That is the horizontal portion of the carotid artery, which means the entire petrous apex has been eroded by the tumor. And you can see the carotid artery on both sides. The tumor has eroded the entire petrous apex. Therefore, the carotid artery is actually standing alone on its own. So whenever you see this, you see that the floor of the sphenoid sinus bulging down like this. Always beware. It always means the tumor has destroyed all the anatomy in the sphenoid sinus, and what is holding it up is the septal flaps on both sides. And the minute we open the septal flaps, as you can see, middle turbinate on both sides, make a hole in the septum. The minute you open to expose the sphenoid keel, what we had was just oozing all over the place. It's not torrential bleed. It's not a shooter. It was just oozing from all over the place. We saw some white structures. We packed that area with Surgicel. We saw some white structure here. We were not what it was. It's a good thing we didn't take any biopsy. Can you see the amount of oozing you get? This is an unedited view to show you the amount of oozing we get. After we packed the area, we actually realized that the white structure was actually the carotid siphon. Can you see? That is the dura. That's the carotid siphon along the cavernous sinus, and there's oozing from all over the petrous apex. You cannot identify the exact location of the bleeder, and that's the carotid siphon that's pulsating away. The same way, we are removing tumor from the optic nerve, and that is the paraclival carotid there. Can you see the dehiscent there? So by the time we sucked out whatever we can, and we saw the optic nerve and enjoying the view exactly like what Nishit said, you must know when to stop. Then our anesthetist, our normal anesthetist was on leave. So a younger anesthetist who was taking over told us, Prof, can you please stop? I don't have a BP. We lost 5 liters of blood in 20 minutes. And we didn't even realize it simply because all we had was just oozing like this. So beware of continuous oozes. You can lose a lot of blood and not even be aware. So I just packed the whole area with fibula and gel foam and Surgicel. And we managed to bring up the BP. And this is the post-op view. I apologize for the quality of the video. It was taken in the clinic. She recovered very nicely without knowing the amount of, she almost gave Vicky and I a heart attack when we heard the BP was unrecorded, like recordable on table. This came back as a neuroenteric cyst. So a few more videos before I stop. So we are opening up the intercavernous sinus. And look at the kind of bleeding that you can get from the intercavernous sinus. Yeah, I just want to show you some videos. I'm only showing 30 minutes is a bit too short for me. I've got lots of bleeding videos, and what I'm showing you is only less than 10% of the bleeding videos. So I will keep the basilar artery bleeds, the carotid artery bleeds, the more advanced bleeders bleeding for the next time I come to India. COVID will be over one day. And India is one of my favorite countries. It's the home of my ancestors, so I'll definitely come again one day. You can see how significant the intercavernous sinus bleed can be. Don't panic. Enjoy the way the blood is coming. The trick is to identify the exact location of the bleeding. In this case, we're using a bit of flow seal on the right location. Wait for a few minutes, and you'll find the bleeding stops very nicely. Okay. This is another example where we're going to open up the intercavernous sinus. This is the intercavernous sinus that is compressed, and that's the kind of bleeding that you will get. So again, identify the exact location of the bleeder, and then you can use either a bipolar to cauterize. In this case, as I said before, quite often our bipolars don't work, especially when we need it. It works when we don't need it, but when we need it, it doesn't work. I'm not sure whether it's a Malaysian phenomenon or it happens everywhere. And we finally stop the bleeding with a Surgicel. Yeah. So I just want to show you two last clips. These are the videos of two patients who had bleeding intracranially. This is a shooter that is coming from the from the branches of the ACA itself. This is very difficult to stop simply because they're intracranial. You cannot pack that area. And we did manage to stop this by using a flow seal. And this is another bleeder that we had recently, just before COVID. A patient with meningioma, had multiple surgeries before. And when we went in, you can see the clips that were used in previous surgery. There's a bleeding that's coming from the ACA. We did stop the bleeding. It took Vicky and I 20 minutes to stop the bleeding. And I'm sure somewhere along the line, we lost 2 years of our life due to the stress. This was a stress test for us because it's you can't pack that area with a muscle. We did stop the bleeding finally with a flow seal. And as I said before, with 30 minutes, I can only show you only some of the clips. This is just an appetizer. I'm only showing you less than 10% of the clips. I will come back to India one day and show you the remaining of the clips. This is probably the most important take-home message. We are only instruments after all. And with this, thank you very much for your kind attention.
Thank you, Dr. Prepageran Narayan. That was a really amazing presentation with some really beautiful videos. And I really like that quote of yours saying, enjoy the way the blood is coming. And that can come only from people who are experienced and those who have handled a lot of these kind of cases with, and those who have had a experience of having a blood bath in the skull base.
Thank you.
Thank you so much. And questions we'll reserve towards the later part. And now coming to the last of the talks is none other than Professor Milind Kirtane. I don't know where to start his introduction from because he doesn't really need any introduction. He's received his MS degree in ENT from the State Medical College, GS State Medical College, and the KEM Hospital in Mumbai. And he's a consulting ENT surgeon at the PD Hinduja National Hospital in the Medical Research Center in Mumbai. And so also the Breach Candy and the Kambala Hill Saifi hospitals. He is honorary surgeon at the KEM Hospital and the professor emeritus at the State GS Medical College. We have actually seen Professor Kirtane over the last so many years, and earlier his main interests were in neurotology, primarily Neuro-Equilibric Society. He was an important part of that. He headed that society. And then gradually he graduated to endoscopic sinus surgery, and then of course cochlear implants. He has trained whole generations of ENT surgeons, and it's my proud privilege to give an introduction regarding him. The government of India has honored him in 2014 with the Padma Shri, the 4th highest civilian award for his contributions to the field of medicine. He's also been awarded with the prestigious Dr. B.C. Roy Award in 2005 by the President of India, and the Quimpro Platinum Standard Award for Healthcare in 2014. he has several publications in index journals and authored books, ontology, so many books which a lot of us have read, and he has guided and steered so many young surgeons into developing expertise in endoscopic sinus surgery and also in cochlear implantation. Now, I can only say that all of those young surgeons and all of those who have been honored to be a recipient of his tutelage can only one day say that I've walked with the lions. So without wasting much time, I hand over to Professor Milind Kirtane for his talk on spontaneous CSF rhinorrhea. As Nishit brought out, spontaneous CSF rhinorrhea was one of the earliest procedures which actually gave the ENT surgeons an insight into what's beyond, what's beyond the dura and how they can go beyond the dura. And as regards talk, I hand over to Professor Kirtane for his talk. Over to you, sir.
Are you able to hear me, Brigadier?
Yes, sir.
Okay. First of all, thank you to the Academy and thank you for that introduction. As you rightly said, I started with neuro-otology, then endoscopic sinus surgery, now cochlear implants. So truly you can say, jack of all trades, master of none. And you talked about lions. We saw the lion just before this. I was getting scared watching that blood here. I can imagine what Prepa must have gone through seeing that blood and the cool way in which he handled it. Hats off to him. I mean, really fascinating what he showed us. Thank you for adjusting my timing. I sort of messed up a little bit on that. And my lecture is going to be something very back to the basics. It's for the average run-of-the-mill ENT surgeon who does not venture into all the things that Prepa or Nishit do with the skull base. I would just like to say that CSF rhinorrheas were traditionally treated by neurosurgeons, which involved a craniotomy, and with the advent of the endoscope, I think we've changed all that, and almost all our CSF leaks are now being done endoscopically, or most of them. Now, it was at the Sage GS Medical College, KEM Hospital. We were fortunate to have a neurosurgery department that cooperated with us tremendously. I mean, we owe them a lot because way back, I remember my first CSF case that I did was in 1975 as a lecturer by the external ethmoidectomy route. So we had already started working in 75 with the extracranial approach with all its advantages. And Dr. Sunil Pandya, who was the head of the department at that time, was so encouraging that he almost pushed us into saying, no, do it. Even if we failed the first time, he would say, do it again, and I'll go transcranially only if you fail the second time. It was very encouraging. And it's because of him that we were able to do a large series of these cases. There are two lessons I learned with him, which are very important. One is, don't fight with your neurosurgical colleagues. I think you have to work in the spirit of teamwork. And that's the spirit with which we've been working. As Nishit must have told you, even for skull-based surgery, that's the spirit with which you work. And the second thing I learned at that time was we were using a lot of muscle to close the leaks. We would take the muscle, mash it up, and pack it into the area where the leak was. And then we learned that fat is a much better material, because you and I know that once fat gets into position, it's very difficult to dislodge, while muscle atrophies very fast and it becomes a fibrous reticulum, because in our revision surgeries, we found the muscle we had put in had completely disappeared. So we shifted to fat and fascia for repairs. And this is a picture of a patient whose sphenoid I had packed. This is 1 year later, and you can see the left sphenoid sinus with the fat still in position, telling me this was a much better material to use. Now, CSF rhinorrhea can be traumatic, which can be iatrogenic or accidental. And it can be non-traumatic, or what we call spontaneous, which may be idiopathic, could be with intracranial pathology like tumors, raising the pressure or eroding the skull base, or even through congenital dehiscences like the foramen cecum, or the debatable Sternberg canal in the sphenoid lateral wall. We are really going to talk, I'm going to talk about one particular aspect of spontaneous CSF rhinorrhea, because I'll explain the reasons why I've chosen this topic. We're not going to talk about these huge defects that these guys create and repair. Now, most of these spontaneous or idiopathic CSF rhinorrheas are associated with raised intracranial pressure. We find that many of our patients of these spontaneous leaks are females more than males, perimenopausal, poor bone density, and with a high BMI, which reflects in the MRI when you see them with empty sella, distorted optic nerves, meningoceles, and even a cavum trigeminal cephalocele. It was a visit by Professor Stamberger in 1985 to the ENT department, and when he demonstrated on a cadaver endoscopy, for the first time we realized all that we were destroying in the nose with our headlight. And with the learning curve, a little bit after that, doing a few cases and not being afraid of CSF rhinorrhea because we were doing it extracranially. In 1989, I had this patient with a CSF leak and a little nubbin of a meningocele there, which I took to the operation theater and decongested, and was without any dissection able to see the meningocele. You know that with the endoscope and the different angles of view that we have, everything from the sphenoid right to the frontal, from the septum to the lateral orbital or to the medial wall of the orbit, you can see a huge big defect there, but all these areas are now visible to us, including the clivus and the lateral recesses of the sphenoid. Therefore, approaching a CSF leak through the nose is no longer a problem. The patients can present to us in a variety of ways of CSF leaks. If you have a patient with a head injury followed by clear leak from the nose, there's no problem in diagnosis or post-surgery. You have spontaneous leaks which just come up with fluid dripping out from the nose. The difficult ones are when the leak is intermittent. And at time when the patient comes to you, the patient may not be leaking. Then the diagnosis becomes a bit of a problem. Patients may come to you with recurrent attacks of meningitis. I had few patients who were treated for a cold and allergic rhinitis, which turned out to be CSF. Patients with headache because of continuous leak of CSF and low pressure or meningeal reaction. I've had patients because I do cochlear implants, bilateral sensory neural hearing loss. And why did that occur? Because there was a meningitis. Why did the meningitis occur? We found a CSF leak which was till then completely missed. And I have had 3 patients who presented only with pneumocephalus and no active leak, but a break in the cribriform plate. Now, we have in our series, which is close to about 700 cases now done endoscopically, almost an equal between traumatic and spontaneous. But are these really spontaneous? For example, this lady with a spontaneous CSF leak, I asked her any history of trauma, and she said no. And then I pointed out to the scar on her forehead, and she said, oh, that was 5 years back. I had a fall from the staircase. But she didn't realize that that fall could have created a small crack in the skull base, not leading to a rhinorrhea, but arachnoid got lodged in that crack. And as water pulsates over a stone or flows over a stone with pulsations of the brain over a period of time, that crack opened up and the leak started. So many of the spontaneous leaks that we have could be related to prior trauma, which has gone unnoticed. The site of leak that we get, cribriform plate has been the commonest, medial lamella or lateral lamella. The roof of ethmoid, which is much thicker because formed by the frontal bone, is not so common and is usually traumatic or post-operative. The lateral recess of the sphenoid is perhaps the next common for spontaneous leaks after cribriform plate. We've got about 80 odd cases of lateral leaks now from the pterygoid recess. The roof of sphenoid again is seen in spontaneous, but far more commonly seen in post-trauma or post-surgery. We've had spontaneous leaks from the clivus, multiple leaks, both spontaneous and traumatic. Now, frontal sinus leaks, we used to use external approaches to close because we were not able to approach them through the nose. But now there are people who would widen the frontal ostium like a Lathrop and Lothrop operation and then approach the posterior wall of the frontal through the nose. And CSF otorhinolaryngology, we've got about 34 cases where the temporal bone leaks appeared in the nose through the eustachian tube, but that requires surgery on the ear. So those we are not talking about here. I think it was 2005, Gautam, who was now in Mangalore as a resident with me, presented at the American Academy cases only from one institute, I think that was KEM, 267 cases of endoscopic CSF Rhinorrhea repair, and almost 80% of these in the spontaneous leaks were from the cribriform plate. So if you have somebody who comes with clear fluid coming from the nose, the most important thing is you first got to recognize that yes, this could be CSF. Then you have to confirm it, and this confirmation you do by testing the fluid for beta-2 transferrin or for beta trace protein. And once you've confirmed that this is indeed CSF, you have to localize the leak. So the localization can be done with imaging, and then with nasal endoscopy once you know where to look from your imaging findings. In traumatic leaks, which we are not covering today, usually you try conservative treatment. If it fails, you do surgery. But spontaneous leaks, as I have explained, is because of gradual erosion of the skull base. It's not going to heal by itself, and therefore you would require surgery in spontaneous leaks. So imaging is extremely important to diagnose the exact site nature of the leak. Do plain X-rays of the skull have any role? I don't think in diagnosis. The only time you could use them is if you had a pneumocephalus, which you wanted to see the progress and see whether progressively the pneumocephalus becomes less and disappears or not, to know the success of your surgery. But otherwise, a good high-resolution CT scan, thin slices in the coronal and sagittal planes would give you usually the site of break and site of leak. If I had a patient with a right-sided CSF leak and I saw this picture, I don't think I would do any more investigations as far as radiology is concerned. I would just try to visualize that area by decongestion and find out whether the leak is there or not. So that was a medial lamellar leak from the cribriform plate, spontaneous leak. Very often, the medial lamella shown by the yellow arrow is intact, and the leak is from the lateral lamella with a little meningocele forming on the side, where you'll have to go transethmoid. Roof of the ethmoid leaks are less common. They're usually traumatic because the bone is tough. And very often post-surgery, we see these leaks combined with a cribriform plate like this, break like this. These are usually post-traumatic or post-surgical. Again, the roof of the sphenoid leaks more likely to be traumatic, while the lateral pterygoid recess leaks in the sphenoid are more likely to be spontaneous. And they have a classical place, and that was the debatable Sternberg's canal, which is thought to be the cause of this defect. The maxillary nerve is usually in very close relationship to it. And we've had 3 cases of spontaneous leaks from the clivus with demineralization of the bone. 2 of them having meningoceles as seen here. Fluid leaks from the, and foramen cecum defect is one more case that we had where there's a huge defect in the foramen cecum with a with a meningoencephalocele coming down. And you can see how the foramen cecum defect has this meningocele with a little bit of the brain tissue also coming down in it. Multiple leaks need not always be traumatic. We have learned the hard way that multiple leaks can also be seen in spontaneous leaks. And that's why for every spontaneous leak, when we localize the site, let's say in the sphenoid or in the cribriform plate, we insist on looking at the CT scan starting from the frontal sinus right up to the temporal bone, because if poor bone density and high pressure in the brain have caused one leak, there could be another site which is leaking or a threatened leak could be there. This was an unusual case post-FES where somebody had not only opened the cribriform plate but the orbit. So the fluid was all leaking into the orbital fat and then coming out. So we had to denude all the fat before reaching the leak area. So if you have a doubtful area of leak, you're not very sure, usually people turn to CT cysternography. But you don't really have to do a cysternography every time. You can do a T2 weighted MRI and you can see the fluid in the brain, the CSF as white liquid. And the way back in '98, with my radiology colleagues, we published this paper in the American Journal of Neuroradiology, where we found that almost in 95% of our cases of CSF rhinorrhea, if we did a CT scan and a T2 weighted MRI, we could avoid a CT cysternography. Here is a doubtful leak. The T2 weighted MRI confirms that, no need to do a CT cysternography. Now here, for example, you see a patient, plain X-ray, plain CT. The T2 weighted shows you a beautiful picture of the dye leaking there, of the CSF leaking there. But this patient came to us from outside already with the cysternography done. So there again, it confirms exactly what the T2 weighted MRI showed you. So this cysternography was not really necessary. But cysternography also is very useful because it gives you a beautiful correlation. Here, for example, you see a lateral lamellar leak with a neck and a meningocele. And at the time of surgery, you see how beautifully the CT cysternography coincides with what you find. The neck and the meningocele matching exactly to what you saw here. So CT cysternography has its place. But what our radiology colleagues now tell us, that if you are in doubt, which is not so in this case, but if you have a leak which is doubtful, you could do a T2 weighted MRI. But if you had to do a cysternography, they prefer to do a gadolinium intrathecal injection and an MR cysternography, where you see how beautifully the leak can be demonstrated. To show you a doubtful case, is this the break? We are not sure. Could this be the leak? Gadolinium MRI cysternography, and you see how beautifully the dye is seen to come, confirming the site of the leak. So now they say, if you are in doubt and you want to do a cysternography, rather do it with gadolinium and MRI than with CT cysternography. Furosin, unfortunately, my anesthetists have refused to let me use it. My hospital has refused to let me use it, but this would be a beautiful way in doubtful cases with a blue filter to find out the leak. Now, to correlate endoscopically, I have a patient who comes to me with a CSF leak from the right nostril. This is what I see in the CT. And what I can do is I can gently, I want to see this location. The superior turbinate is just starting to, I know that I have to look for this leak near the superior turbinate. Sometimes the anterior ethmoid artery is a good location finder. So this is the turbinate coming in my way. I don't want to fracture it. I don't want to cut it. All that I would do in this case is very gently pack between the turbinate with xylocaine adrenaline. Be patient. And then you go in and then you see beautifully the middle turbinate here, the superior turbinate here, and exactly where the CT scan showed us, you see the meningocele. No need to do any dye study. And if you ask the patient to do a Valsalva at this time, closed palate, ask him to strain, and you can confirm that that is indeed the site of the leak. Now, let us concentrate on the medial lamellar leak. The reason why I'm talking about this is the commonest spontaneous leak that most ENT surgeons will face. And I was really exasperated when I saw the various techniques. I was at a workshop where somebody just cut the middle turbinate. Then he not only cut the middle turbinate, but tried to transpose it in the cleft, olfactory cleft, to seal the leak. I've seen people do an ethmoidectomy and then cut the middle turbinate to approach a leak which is medial to the turbinate. Use fasciolata, use muscle cartilage to seal that leak. I've seen people using a Handa flap for a medial lamellar leak or a local septal flap. And there are still some die-hard neurosurgeons who say, no, it must be done transcranially. Now, I'm going to show you the technique that we've been using. And this is the lady that we're talking about, 52-year-old female, meningitis, which we treated. Now there is no more meningitis. This is the area, beta-2 transferrin positive. The MRI confirmed that this is the site of the leak. Now, the surgical treatment that we practice is what I'm going to tell you. First of all, sit down with the radiologist and confirm the site on imaging. Then at the time of surgery, decongest and identify the leak, expose the pseudomeningocele. Bipolar the pseudomeningocele. You haven't dissected anything at all. You've gone directly there. Then after you've bipolared it, create a raw area with a curette in the surrounding area. Plug the defect with fat, fascia, or Surgicel. Now, the defect from the medial lamella of the cribriform plate, although you may have a large meningocele, the defect is usually very small, and then there is a balloon. If you try to plug the defect, you'll only enlarge the defect. Anywhere else, roof of ethmoid, sphenoid roof, lateral wall of sphenoid. We always try to plug the defect, get the tissue into the defect, so there is a mushroom kind of tissue inside and outside. But in the cribriform plate, medial lamella is the only place where you do not try to plug, but cover the defect. And we don't use fascia, we use fat. Because that angle in the attic is so narrow that when you try to put your fascia inside, exactly like the anterior blunting you get in tympanoplasty and the anterior annulus, because of the acute angle, you might leave a little gap between the fascia and the roof on top and the repair might fail. But if you use fat, it's sort of semi-solid, semi-liquid, so you can push it into the area. Fascia is connective tissue, fat is connective tissue, both work equally well. You hold it in place with tissue glue, gel foam, Merocell, which will leave for about 4 days. And now for these leaks, we used to use CSF drainage as a routine. We don't do that anymore. So let's look at the procedure. That's the leak confirmed. And now you watch the surgery. You have decongested the middle turbinate and identified the meningocele. Bipolar cautery. Like Dr. Prepa said, I use a regular bipolar cautery. Cauterize it. No dissection, mind you, no dissection has been done, just decongestion. Then just surrounding the area of the leak, create a raw area, not only on the skull base, but also on a part of the septum and the medial wall of the turbinate. So you have a sort of three-dimensional raw area. Pick out all the mucosa that you've curated out. There you can see the leak, it's a smallish leak. And now all that you need to do is somebody has harvested the fat from the thigh. Take a sliver of fat, okay? That's the sphenoid ostium at the back. You're not going to go near that. Take a sliver of fat, and you're almost watching this in real time. Just that sliver of fat attached to the fascia, superficial fascia, you put it there. Now you want to make sure that you pat it in completely, covering the leak and the raw area that you've created. So I use a little Surgicel to hold the fat in place. And I still want to sort of push it in like a putty, you know, to completely seal that area. So I do that by putting a gel foam on top. And now we take a neuropatty and very, very gently, if you squeeze too hard, the fat will just slip off at the back. So very gently, you push the gel foam against the Merocell and the fat, and you make sure that you've pushed it hard against the skull base. Now you take out the patty. I even take out the gel foam, gently suck it out. So now you got the fat supported by the Surgicel in place. You take the fibrin glue, which has already been prepared, and you put the fibrin glue to hold the repair in place. Now we put a little gel foam on this. 2 pieces of gel foam and Merocell. The idea is when you remove the Merocell, you can pull on the gel foam, but you will not be pulling on the repair that you have done. And then a piece of Merocell, which is removed after 4 days. Post-operatively, bed rest, we avoid increased pressure by avoiding constipation, cough, etc. No straining. I give antibiotics for a week, and we put them on acetazolamide. If the leak is not very high pressure, we don't do a lumbar puncture or drainage. In other leaks which are high pressure, if you find that the pressure is high, you might want to do lumbar drainage at the time of surgery, or even put in an indwelling catheter for about 3 days to 4 days. The neurosurgeons come in. If the pressure is high, they might want to do a shunting procedure. And we have read about this, but we've not had the occasion to find a venous stenosis, say the sigmoid, the lateral sinus being stenosed, where people have said if the sinus stenosis is the cause of the increased intracranial pressure, people have even advocated venous stenting when the pressures are very high. But otherwise, we've had the occasion to do lumbar drains in some cases and shunts in some cases. The patient is asked to lose weight. We increase the bone density with vitamin D, calcium. And this is what I wanted you to see. This was the pre-op leak. And post-op, look at the huge amount of adhesions that we produce there. This is one time the adhesions are friends of the ENT surgeon. You can see that these adhesions are solid repair, and this is not going to leak again. So I had one of my colleagues, Dr. Achala, who in one hospital that I work, I do these cases I've done them at KEM, at Hinduja, Breach Candy, Saifi. but she analyzed the cases from one particular hospital where we could contact patients over the last 17 years and 49 patients with medial lamellar leak, which were repaired. And I was happy to note that we could talk to all of them and none of them had recurred. 4 of them had a re-leak, which I had to repair, but the leak was on the opposite side, so it was not the failure. But that also taught us a lesson that multiple leaks are possible. I had only one patient where I failed to close the leak, but that patient had been operated 4 times earlier, so it wasn't really a classical medial lamellar leak. I'll just share that with you. It's important that you learn to read your own CTs and look for multiple leaks from the frontal to the temporal bone. Now, this is, for example, a lateral lamellar leak, which I have started dissecting, but I want to look inside to the medial side, and I see that there is also a leak, a meningocele on the medial side. It's not leaking, the leak was lateral. There is another meningocele. This is a spontaneous leak, mind you, at the back. Spontaneous leak from the lateral lamella, 2 meningoceles here. And as you come forward, you see multiple areas. There is one area here, and you can see these little bulges, which are sort of arachnoid showing through the mucosa. The mucosa is intact. But once I repair the lateral lamellar leak over a period of time, these are going to open up. So if you see these, then at this time itself, you would want to repair them. I had some very unusual presentations. One was this case of a medial lamellar leak. The patient came to us leaking from the left side. You can see on a CT cystoscopy the dye on the left side. But the patient was leaking from the right cribriform plate, making a hole in the septum, and then coming out into the left side. This was a right-sided CSF leak, but when we did the CT, we found it was coming from the left medial fossa leaking into the right sphenoid. So if we had gone and tried to repair the right sphenoid here, we would have had a tough time. This was an unusual leak because the leak into the concha bullosa, emptying into the nose from the natural ostium of the concha bullosa, which faces posteriorly. So we had to excise the concha to access the leak. And as I said, learn to read your own CTs. I remember sitting in the OPD, sending a patient for CT cystoscopy in the days when we used to do it routinely earlier. And the resident from the radiology department called up and said, "Sir, your patient's got a right-sided sphenoid leak." And I said, "But my patient is leaking from the left nostril." So she said, she sent me this picture and it showed a leak in the right sphenoid. And I was confused. "Are you sure you haven't mixed up the side?" She said, "I'm very sure, here is the left." Then we saw the other cuts. And then you see, oh my God, it's a bilateral sphenoid leak. You can see the empty cella. And then we saw the front cut and you realize that this is the left sphenoid sinus. This is the right sphenoid sinus. But the point is, I am not seeing a break from where the leak is entering the sphenoid. We kept on looking. Definitely left sphenoid leak, but no break in the sphenoid. So where is the leak coming from into the sphenoid? And we looked at the axials and we found the leak was coming from a watering can-like clivus. The leak was coming from the clivus. So you need to sit down and study your CT scans with the radiologist. And after you do the surgery, share the information with them. This was the patient where we failed. This was a medical doctor who came with 4 repairs already attempted. Right side cribriform leak, but see what's happening. The dye is coming down into both the nostrils, and look at the septum here. It's leaking, and there is some other point of leak here. Can you see this? And we tried to repair this endoscopically. For 1.5 months, the guy was okay. You see this nasal septum, it's completely filled with CSF, and the CSF is coming down into the floor of the nostril here. And after 1.5 months, where I thought I had succeeded in closing the leak, it opened up again. Ultimately, he went for a transcranial repair. So you could fail. Nobody can say you have 100% results. You could fail if your defects were very large. There were multiple defects which you failed to recognize. If the leak was very high pressure and you did not do a series of diversion. Sometimes you've got the wrong site identified. I've had somebody repair the middle, the cribriform plate when the leak was actually from the lateral wall of the sphenoid. You had small defects which I showed you which were not leaking, which might open up after you've sealed a big defect. I remember a case of a sphenoid leak which I did. I thought I'd done a good job. Patient kept on leaking. I reopened. I took Nishit with me. And Nishit will remember, we took out all the fat from the sphenoid. The leak which we had plugged with the sphenoid plug was perfectly intact. And we realized that we had missed a small leak in the posterior ethmoids, which we had to repair. And lastly, this kind of a leak is not something that you want to attempt endoscopically. So as an endoscopic surgeon, you don't have to be scared of CSF. When you're operating, it can come anytime and you should be perfectly sort of competent to repair the leak when it comes. Of course, it's not something that you want to start doing as your first few cases. Train yourself well. Cadaver dissection, there is no replacement for it. You have to train your skills on cadaver dissections, attend workshops. It's never too late to learn. That's younger me, Dr. Ingle, who was my chief, and that was his chief, Dr. K.L. Shah. And they were watching what I am demonstrating. And now when Nishit or Hetal are demonstrating, I am there standing. Dr. Ingle is no more with us. This man at 90 is still willing to learn. It's never too late to learn. Cadaver dissection, practice to make yourself perfect. Thank you very much for a patient listening. The reason for the medial lamellar leak was it's easy to repair without the terrific dissections which I've seen people do for repairing that leak. And I think since this is one of the commonest leaks that people will face, the average ENT surgeon, not the skull-based surgeons, that's the reason why I selected this particular aspect of CSF to talk on today. Thank you.
Thank you, Professor Milind Kirtane. It's always a pleasure to listen to you, and with so much of experience behind you. And you were one of the people who started this in this country, and rest kind of just followed you. Of course, but you were one of the beginners, and one you started, set the trend for doing these skull-based procedures in this country. Thank you, sir. Thank you so much for such a wonderful disposition and making it look very simple, although it's quite a trying experience to handle these cases. Thank you. I have all the speakers for today, and let me just go to the question side and okay. Neelam, Dr. Neelam.
Yeah, I'm here.
Yeah, you're here. So, well, some of the questions which have been asked, one is Dr. Manas from Visakhapatnam. Of course, he's asked how to identify the frontal rhesus and the variation. I think you covered most of it, and then at length, and how to identify various anterior and posterior and medial approaches to the frontal rhesus. Now, the question which has all been asked is, what is the difference between a nasal beak and a frontal beak?
Yeah, so there is no anatomical structure like the nasal beak. The frontal beak is actually the superior end of the frontal process of the maxilla. The nasal beak is something which is more of a deformity that one talks about in rhinoplasty.
Okay. The next is, okay. Now, when do you decide to do a modified Lothrop procedure? In the sense, as a primary procedure, or after failed frontal sinus surgery? When do you take a call on doing a modified Lothrop procedure?
I've been fortunate that I've never had to do a modified Lothrop as a primary procedure. And most often, even if you look at literature and our experiences, it's usually indicated more for revision surgeries. When you're going in, when a patient's been operated maybe 2 or 3 times. An anatomical indication could be a very, very narrow frontal ostium. And the trick usually is that, if you look at your frontal ostium suction, it's got a diameter of about 3 millimeters. If you feel that the frontal ostium opening is so tight that even your frontal ostium, your suction is not going in completely, that is the case where you may be considering, you might have to do a lot of drilling. But as a primary procedure on a virgin case, I wouldn't suggest a modified Lothrop.
Okay. One of your slides, you had shown the thickness of the frontal beak if it is kind of more than 1.5 5 centimeters, if
Yeah,
I'm mistaken. So
then that's an indication for a
that could be
modified lathrop.
that could be an
Normal
indication.
would be about 7 millimeters. That's what it is. 7 to 8 millimeters, it's normal. If it's more than 1.5 centimeters, but again, it's not just the thickness of the frontal beak, it's also got to be in relation to the anterior-posterior diameter of the frontal recess. So it has to be both.
So these thicknesses and all can be preoperatively assessed with on a CT scan. Okay. Now, having done these endoscopic frontal procedures, when do you take a call on converting to an open procedure when you when these when the symptoms don't abate?
I can't recollect having converted to an open, but I do recollect having, resorted to using a trephine when I'm really lost to give me an idea of where the ostium is. But like I said, in places where you have image-guided systems, which I don't have in my hospital, even an image-guided system can help you. If you don't have an image-guided system, then a trephine as an adjunct is a very helpful procedure.
A trephine, okay.
Yeah. Okay. And I mean, I couldn't cover that because of absence of time, but if you are going to do a trephine, then, it's very important that you do it from the inferior wall because thereby then the risk of osteomyelitis is much lesser. The inferior wall of the frontal bone has no bone marrow. So the chances of your thereby causing any osteomyelitis secondary to a procedure are much, much lesser.
Okay. Understood. Now, whenever you do revision lathrop, you had to do revision lathrop and you encounter a lot of new bone growth, new bone development, which is distorting the anatomy and making your revision procedure, revision lathrop even more difficult.
Yeah, that would be an indication for a lathrop because that's what's usually happened because of the primary surgery. There's been a lot of neo-osteogenesis and you do have a problem there. And that's where you will need, an image-guided system or a trephine to help you identify at least where you can start your drilling from.
Okay. Yeah, thank you, Neelam. I think most of the questions which have been put forward have been answered by you.
Okay, can I just leave? I have a COVID round duty, so I have to leave now. So can I just say thank you very much and bye to all the other panelists and thank you so much.
Thank you, Dr. Neelam. Thank you. It was a pleasure having you around and listening to your great talk and very informative. Thank you so much.
Thank you.
Dr. Nishit, there are questions in the sense, basic questions regarding how does an ENT person train himself for a skull-base procedure? There's a lot of young surgeons are keen to venture into that field.
Yeah, I think there are a number of ways. Obviously, your FES training has to be very good because unless you're comfortable with work in the frontal and the sphenoid sinus and able to do a good CSF repair, and actually I was very fortunate to have worked with Dr. Kirtane for all these things. That is your basic foundation, is to be a good FES surgeon and a good CSF repair surgeon. Then as you advance into the skull base, you need to sort of learn new anatomy, which is intracranial. Your defects are going to get bigger. And most important is you have to learn to work as a team with somebody else without there being an ego clash or, I want to do more sort of situation. I think without doubt, the cadaver is your best training ground. And the more cadavers you do, the better it is. Then of course, more workshops you attend, the more different people you see operate, you see different techniques, and you can sort of make an amalgam of different techniques, read books. And today, I think youngsters are very fortunate to get a whole host of YouTube videos and see so many surgeons doing live surgeries on the net.
Yeah. Another question is, how do you convince your neurosurgeon to team up with you? It's a, I think it's a daunting question which I'm asking you.
Yeah, no. This is a genuine problem that I think most ENT surgeons face.
Yeah.
Because you have to be, I think, learn to be friends first. Because if you're not friends, and Prepa will stand me out on that he and Vicky are good friends, you cannot work together for any sustained period of time. And if the neurosurgeon only wants to do pituitary surgery, he will learn that very quickly from you and throw you out. So it really depends on what your goals are. Sometimes the ENT surgeon learns the tricks from the neurosurgeon and decides to go on his own. So if you want to do extended surgery, want to go beyond level 1 surgery, it is essential that you work together as a team. How you find that, you probably need to showcase the kind of work that you do, maybe be part of an institution or a multi-speciality hospital where you have lots of other doctors. And then hopefully you can team up with someone. Rappa, you want to add something to this?
That's a very good question. I think most ENTs will not listen. Most neurosurgeons will not listen to an ENT.
Yeah.
So if you go and tell a neurosurgeon, "Oh, we can do this endoscopically," they're not going to listen to you. They will only listen to another neurosurgeon. So the best way is to drag him or her to another center where the surgery is done endoscopically. And if they see Nishit and Pujari operating once, they will never go back again. That is the only way to do it. No matter how many videos you show, it's not going to work. You literally have to bring them to see an ENT and neuro in action, and they will only listen to another neurosurgeon, not an ENT surgeon, initially anyway. I hope that answers the question.
Yeah, I think that's the right way to take your neurosurgeon along with you to a skull-based workshop and make him see and experience what the team is doing, what the team can do, and that's how you can probably befriend a neurosurgeon and work as a team together.
And the other point that Nishit brought up, I think, is very right, because skull-base is not just pituitary.
Exactly.
Pituitary is like tonsillectomy in skull-base. Only if you master pituitary, you move on. So you may be able to do a pituitary on your own. The neurosurgeon may be able to do a pituitary on his own. But if you want to do anything more than that, the ideal combination is always an ENT and neurosurgery. Absolutely. That is why, like Nishit, I disagree with an ENT doing everything himself. You will just cause, then neurosurgeons will start saying that there's no point working with these guys. They're going to take it for themselves. You see, it's very simple. You wouldn't like a maxillofacial surgeon doing a cochlear implant, would you? You wouldn't like a maxillofacial surgeon doing a FES. So if you don't want people to enter your boundary, then you have to give the same respect to other people as well. The world is big enough. There are enough things to do. That's my humble personal opinion anyway.
Thank you, Dr. Prepa. So Dr. Nishit, when do you actually, when you are operating, when do you actually hand over the reins to, I won't call it the reins, but the charge to a neurosurgeon to take over? And of course, you are also part of the team, but when does he take the charge?
So I won't say there's any defined time or defined boundary. Usually the practice was that when you need an extra hand, like when you do drilling, then you need one more person, which can be a resident, and I could do the drilling if the neurosurgeon is not in the theater. If he's ready and prepped, then he would come in and do it. The only thing I would ensure is that before opening the dura, any intracranial work, the neurosurgeon is in the theater. And for me to do any intracranial or intradural work, it must be at the invitation of the neurosurgeon. So the neurosurgeon's in the theater and says, go ahead. I'm watching, or I'll come back in 10 minutes. You go ahead. Sometimes during surgery, also when removing tumor, we find that there's a problem, something's not coming out. So he'll say, okay, you try removing it. So then you would go in and try and remove with angled scopes and angled instruments, which sort of work we are more used to than they are. So it is a flexible thing. I would say that you learn to work together, as you know, and then you're not really stepping on each other's toes. You're just helping with the other person.
Okay. Now, when you have tumors which are very close to the big vessels, how do you get used to using a Doppler, and how easy is it to use, or how beneficial is it to use Doppler in these kind of situations?
So there is no tumor intracranially which is not close to a vessel or a nerve.
Yeah. I mean, the major vessels like
so preppers videos. So I think today a Doppler is an essential part of skull-based surgery.
Okay.
And really it becomes very important to use a Doppler correctly, because it does give you an indication. It is the only true navigation instrument, because as your tumor is removed, things move, structures move. So you cannot depend on your pre-op navigation to tell you where your vessel is. Only a Doppler will tell you where your vessel is now.
All right.
As you go through tumor.
So is that a better equipment for you, or an image-guided procedure?
We use both. We use both, of course.
You use both of them.
Because your image-guided with angiography will tell you where your vessels are much in advance, and your Doppler is going to tell you when you're close to the vessel. So you certainly want to use both. Bone landmarks will not change. So your navigation system is always dependent on bone. That will not change, and that's useful till the end of the surgery. It's your soft tissue which can move.
Soft tissues. Thank you, Dr. Nishit. I think most of the questions you've answered them. Dr. Prepageran, yours was amazing talk and amazing video, and those were some of the scary videos. But it was great to see you handling those with so much of comfort and ease, and really proud that you're doing such great work.
Thank you.
Now, there's a question about irrigating endoscopes. These kind of tumors, whenever you're dealing with, wherever you're anticipating a lot of bleeding and hemorrhage, what is the utility of this irrigating endoscopes? Are they just kind of superfluous, or they're really useful?
That's a good question. We have one, but we've never used it because it does take a little bit of space, number one. Number two, sometimes you can have water that miss on top of it. So we don't use it. So what I use is just, my fellow will be holding a 20 ml syringe, warm saline with a J sucker at the end of it. So whenever the scope becomes smudged or becomes dirty, they will just run the water from the tip of the J sucker along the scope. So that usually cleans the scope. So that is usually more than enough to do the surgery. Yes, that's more than enough. You can use the irrigating ones, but they do take space, number one, and they can cause smudging of the scope where it's not so clear. So we don't use one.
There's a question from Dr. Jamil from Parabur. He wants to know, how do you stop arterial bleed? I think your presentation has shown a lot of these cases where there is a direct spurter. Is there anything else you want to add onto that?
Well, I didn't show, like I said, I've only showed less than 10% of the videos I have.
Yeah, exactly.
Yeah, so we have videos on basilar artery, ACA, ICA. So the next time I come to India, when the COVID is over, I'll show those videos. But as much as possible, don't have a ICA bleed. A lot of people like to show ICA bleeding, and quite often they are avoidable. If you're very close to the carotid artery, you have a tumor next to the carotid artery, you can leave some tumor behind. To stop the ICA bleed, is usually use a muscle patch. But I've seen cases where although the bleeding has been stopped during surgery, the patient goes down to the radiology for stenting, and after stenting, they will usually give some amount of heparin to prevent thrombosis. And I've seen patients who have developed intracranial hemorrhage because of heparin. So there is a lot of complications apart from the bleeding. There's a lot of morbidity involved. So as much as possible, try not to have an ICA bleed. If that's
right.
that's probably the best take-home message.
Right. I wish the audience had the honor and pleasure to see more of these scary videos, but because these are the videos which eventually make you learn.
Next academy meeting. The
Thank you very
next
much.
academy meeting next year, when the COVID is over, when they allow me to enter India.
Thank you, Dr. Prabhakar. That was really nice.
Thank you very much for having me.
And coming down lastly to Kirtane sir. Well, you just said about the CSF leaks which you have done over the past so many years. It was a brilliant disposition, sir, on your and all your experience on dealing with these kind of unusual kind of CSF leaks. Now, there are times when you close a leak successfully, patient is all right for a couple of months, and thereafter the patient again intermittently starts having small leaks. You put a patient, let's say, on acetazolamide, and what do you do? I mean, do you go in again and do it, or just wait and watch? How do you follow it up, sir?
You know, if this were to happen in the immediate post-operative period, you would perhaps do a lumbar puncture, drain the fluid out, drop the pressure, and hope that the leak which is coming from your repair site might seal by itself because you've created a little trauma there. Okay. But if it happens after 2 months, then you will have to try and see whether it's your repair which is leaking or another leak which has opened up. So this is where again imaging would have to be done, either direct visualization if you've got an open field where the leak is coming, or you would do a cysternography and try and see from where the leak is coming, because that leak will have to be tackled on its own merit. So it may not be from your repair, it may be from an adjacent site.
That's right. That's right. So now, sir, you showed these cases.
The repair is going to fail. Then it is very likely that it will open up much earlier. It won't wait for 2 months and then.
2 months. Okay. So those leaks, there are leaks which the patient complains there is a leak, and maybe in the outpatient he's come and you've been able to witness a drop or two, but your image does not demonstrate a leak. Have you faced situations like this, and then what's the kind of how do you plan to go around for these kind of cases?
This has happened in the sense the patient said a couple of drops come out, or you've seen it, and you see the CT scan. In the past, we didn't have such thin cuts, so we might have missed it. Today, you have cuts which can go down to such thin cuts that you're not likely to miss even a small defect. But if that happens, you would want to do cysternography. This is the kind of case where I think intrathecal fluorescein would also be of great value. I have no experience in that. But if you do let's say a CT cysternography, then this is the practice that we started, that we leave cotton pledgets in the nostril. Okay. So now at the CT cysternography also, the radiologists fail to show you exactly where the leak is.
Okay.
You take the pledgets and you put them and scan them and see whether the pledget has taken up the dye. But then you know that you have not been able to demonstrate it, but the leak is still definitely there. Also, we've had this happen when we've completely missed out temporal bone leaks coming through the eustachian tube, because the cut stopped at the sphenoid. So that's why I mentioned in my talk that it's important to look from the frontal right to the temporal bone. And with the combination of this and cysternography, I think we've always been able to ultimately spot the leak. Yeah.
Okay. Now, one question which is asked by patients, especially the kind of patients which you showed, obese, elderly, middle-aged female with empty sella, benign intracranial pressures, raised pressures. Now, a leak which happens after breaching the bony protections of the skull base. Now, when you repair a leak and you create an addition, as you said, would it or would it not breach those also? When it can breach a normal intact bone, what's the likelihood that this can recur in these after post-operative created in addition?
Yeah, so one thing is that, as I said, post-operatively, you're going to try and take care of the factors that really led to the leaks. So whether it's obesity, raised pressure, poor bone density, all that you'll take care of.
Okay, sir.
Secondly, these spontaneous leak occur because of the CSF pulsating against a hard bone, which is non-pliable. What I showed you was a thick adhesion that forms over there. First of all, it's because of the CSF leaking through that the dura is not able to heal. Once you stop the leak, that dural tear repairs itself, fibrous tissue forms there, and then you get a thick load of adhesions, which, as I said, for once are your friends and not your enemy. And being a soft tissue adhesion there, the CSF is not going to erode through it like it eroded through non-pliable bone. And now, as I said, we've got 17 years with these patients following up, no leak. So I think that repair is strong enough.
Thank you, sir. Thank you so much. Now we crossed 1 o'clock and it's time for the webinar comes to an end. And extend great thanks to all the faculty, all the speakers, and all the delegates who've been watching us closely and listening to the deliberations on Sunday morning. And thank the organizing committee also for organizing such a brilliant webinar, making all the great speakers in their own field to come together and present this wonderful disposition to for the ENT fraternity. Thank you so much. And Vijay, thank you. A special thanks to you for coordinating the entire event, and thank you for the thanks to the Indian Academy also for having this webinar today on this Sunday. Thank you so much.
Yes, sir.
Thank you all, sir. Thank you so much.
On behalf
all the speakers. Thank you so much.
Sir, on behalf of IAOHNS, I would like to place my sincere thanks to Sun Pharma Pharmacare division, especially Mr. Mahendra Verman and Mr. Ranjit Kadam and their entire team who made this program to reach all part of the country, and almost more than 1,300 participants are watching this live discussion on this Sunday morning. I would like to thank all the speakers also who readily agreed to share their views on these fantastic topics, what they have chosen. And I'd like to thank you also, sir, who readily agreed and immediately said okay for moderating this session very brilliantly. Thank you very much, sir. I would like to ask Mr. Deepak Bora to say a few words and conclude the session.
Thank you, Dr. Vijay Krishnan. Thank you, sir.
Video is not.
Yeah, video is blocked, sir.
Okay.
Yeah, sir. At the outset, I would like to thank a big thank to all the eminent speakers in the ENT fraternity. So thanks a lot for sharing your valuable time and adding a lot of value to the ENT practice all over the country, as well as all the audience from outside the country as well. It is all because of your trust on Sun Pharma and our quality brands like Montek FX, Cepodem XP, Raciper D, and Betavert and Niconia. And I would like to extend my big thank you for all the ENT audiences who have shared their questions as well. So thanks, Dr. Vijay Krishnan, and thanks a lot. Because of your lot of perseverance and your energy, we are able to conduct these academic sessions for all the doctors every week, sir. Thanks a lot, sir.
Thank you. Thank you also. Thank you all the speakers. Thank you, sir. We can conclude this.
Thank you so much. Bye.